without further ado, Dr. Zaghi, make it number 18.
I want us all to recognize how much work goes into organizing these meetings. How excited are we to be here all together again for the first time since Florida? And can we all give a standing ovation and a round of applause? Thank you so much. And a big round of applause to all of you guys for being here, year after year, coming back to learn more. We are here for a quick run, okay? It's 3 hours, but it's going to go by like it was 10 minutes, all right? I have all of the slides here. If you just put your QR code, I'll give you guys a second, all right? You'll have another chance in a second with the bit.ly code. I'm going to give you our entire Breathe Institute protocol as it applies to lingual frenuloplasty. We'll be talking about how to assess for tongue tie, where the current research is, where the current research is going. We're going to be talking about tongue space. I'm going to show you 4 full-length cases. I'm going to show you a case I did from 2016. I'm going to show you a case I did recently. We're going to show you the implementation of lasers, and we're going to keep this dynamic. So based on your feedback, I'll spend more or less time on different topics. For those of you who haven't met me, my name is Dr. Soroush Zaghi. I'm a graduate of Harvard Medical School, UCLA ENT residency, and Stanford Sleep Surgery Fellowship. Show of hands, who here has heard me speak at least one time before, either in person or video? Fantastic, thank you all for coming back. I am sure you're going to take away some knowledge nuggets. Who here is new? Never heard me speak before? Welcome, are you guys the residents from UNLD? Are you UNLD residents? Did you guys make it? Fantastic, thanks so much for being here. And I welcome you all. Since graduating from school, perhaps the biggest opportunity that I have had for learning is my role as medical director of the Breathe Institute. You guys were fortunate to hear from many of our colleagues and affiliates of the Breathe Institute, where we were focused not only on patient care, but also research and education. And our institute is dedicated to providing a multidisciplinary approach to pediatric and adult sleep and breathing issues, starting from infancy to no age limit. We take care of everything from tongue ties, lip ties, but also ENT, maxillofacial, dentistry, nutrition, bodywork, lactation consulting. We're really trying to bring the whole community together. And today we'll be talking about one little segment, which is tongue ties, but really we have to understand this in the bigger picture of things, which is breath. And after all, breath is life, and if you breathe well, you will live long on earth. And while breathing is life, these things are simple, but they're also complex. And the reason I would imagine that you guys are all here today, after taking many courses and doing tongue ties on your own, is to learn to become a master. Am I right? Who here wants to be a master of their domain? Who here wants to be a master of oral function? Let's see a show of hands. A round of applause for you guys. Okay. Who here wants to be a master, right? Keep that in mind. You want to be a master so you can feel confident that you are giving the best care to every patient in your community. But to be a master, right, before you can be a master, you have to understand what that means. So just take a second and think of a master sommelier, right? Have you guys seen these wine specialists who can smell a wine and tell you which region in the world it came from? What year, what taste, what flavor, what note? That is what I want for you guys as it relates to tongue ties. Okay? Think of a master barista who makes that perfect cup for each individual, so that individual taste and needs, and think of the master virtuoso violinist. That's what we want for you guys. But can you become a master just by reading the books? By reading guidelines, doing a literature review? Is that going to make you a master? No. Becoming a master requires more than that. It does require the introductory coursework, advanced coursework, but it requires experience, practice, and mentorship. And that's what we're here to build today. Okay? We're here to help guide you guys along this journey, no matter where you are. And we have to recognize and understand the life cycle of learning. If you consider a frog, frogs don't start out as adult frogs. They start out as little eggs. And the eggs grow to tadpoles, and the tadpoles grow legs, and the legs makes into a froglet, and then you get an adult frog, right? And just as we're learning about tongue ties, we recognize that first you have to recognize it, understand the importance, start treating easy cases, start treating more complex cases. And this really applies to anything we want to learn in life. I love to ski, all right? This is me just at Mammoth a few weeks ago with my family. And there's just something about it that just really brings me into the moment, the nature, the serenity of it all, being in control of the skis and the elements, and it would really make me nothing happier than one day to be able to ski with my son Max, right? So that's my goal. I want Maxim to join me on the Black Diamond slopes of Mammoth, just as I want you guys to join me on the Black Diamond cases, the tough cases, not only the easy cases, the tough cases that are going to come to you from all over the world. But how are we going to get there? Are we just going to jump in? No, you got to take it step by step. So first we teach them how to sit, then we teach them how to walk, then we expose him, right? We show him, and then we start to walk in the snow. Building a familiarity, gaining practice, being okay, and you see he goes a little off track, right? And that's why you need a mentor there to help keep you on track. And the same is true for chewing, swallowing, and diet issues. Here he was, I've shown this video to you guys before, learning baby-led weaning, learning to feed himself, and then he goes off track. He makes friends with the family dog, and what does he do? All right, so here he needs a little bit of mentorship, right? That you need to use your hands and not your face. And then here he is chewing up whole pieces of steak, okay? And that's one area, but everything that you do requires that step by step. And you know, your children are watching me, so here he is literally in my footsteps, watching me help take care of patients, inspiring, and he really wanted to be here at the conference today. I just didn't have enough room for him in my bag. So the basis of the lecture today in our teaching style at the Breathe Institute is based on my personal experience in residency and fellowship. I spent 1 year in just general surgery, okay? I took care of patients with pancreas problems, abdomen problems, cutting off the knee, reconstructing the face. I did 1 year of that. I did 5 years of head and neck cancer surgery, and I did 1 year of maxillofacial surgery advancement. I overtrained. I got training from all over so that I could really specialize in this one topic. And it's not alone for me to have these skills, but I want to share them with you guys, and I want you guys to start to learn how we can really take these cases to the next level. And so, just a show of hands, who here believes that they're at the introductory phase of releasing tongue ties? Just a show of hands. Who here believes their introduction? Who here thinks they have the basic skills, they've started it, are just starting to get more practice? Okay. Who here is in the getting the practice phase? And who here is seeking advanced mentorship? Great. Once you got it down, you're not done. You've just begun, right? Then it goes to teaching and research. And now we have affiliate centers, I see a few of them here with us here today, who are already experts, who are already treating thousands of tongue ties, who come with us to learn even more. And the incredible thing is that I have had the opportunity to personally show 10 cases to each of these individuals, but I've also watched them. So even though I'm a teacher, I'm also a student. And over the course of the last couple of years, I've had the opportunity to fly to over 20 different offices and watch 20 different people, right, do 10 cases. So I've gained that kind of experience. And I'll tell you that that's like perhaps the most gratifying part of it, is to teach and then learn from your student, right? And that's the kind of attitude and mentality that I trained for at Stanford, where Dr. Liu taught me the procedure, and then he came back and he trained under me to advance his own skills. And even then, we're not done. We do research together, we collect data, and research is just so important. And we'll learn why in just a little bit. Okay? So in the course today, we're going to be talking about the new research that we've developed. We're going to be giving you an update. And we're going to be moving quickly. I'm happy to take questions along the way. We'll keep this educational and interactive. You guys in? Yeah? Woo! Some energy? Yeah! There you go. There you go. All right? Fantastic. Here's the statement that we're supposed to give. And you guys all got the slides? Okay, fantastic. The first thing, you guys, unfortunately, you guys are our ambassadors. You guys are our voices on Facebook, right? So the first thing you guys have to know about if you're treating tongue ties is this clinical consensus statement. It bothers me, but it's out there, all right? It's a consensus statement. Who here has seen this before? Okay? Yeah, it's a consensus statement. They took 30 ENTs in a group like this, and they asked them, what do you think? Does tongue tie cause speech problems? What do you think they said? They said no. They said, no, we don't think that. It's never been seen in the textbooks, nothing like that. And they said, what do you think? Does tongue ties have anything with sleep apnea? And again, they said no. So if you're going to be treating tongue ties, you have to understand that this is a consensus statement. This is just mere confirmation bias. These doctors don't quite understand what we're talking about. We're not talking in the same language. And what we really want to be doing is research on higher levels, as we'll be talking about, that systematically investigates these things and pushes them forward through observation, hypothesis, and testing. And it's so important to go through the various stages of the research, because if you miss a step, like the methodology, then you'll see that the results are less than desirable. Okay? There's 4 key terms. I'm going to wait on this slide until we all learn these 4 key terms that I want all of you guys to know. The first one is confirmation bias, and this will be in a discussion, okay? Confirmation bias means I believe what I believe, okay? And whatever you tell me, I'm going to continue believing that. Does that make sense? Any questions about confirmation bias? There's another one, it's publication bias. Where's Dr. Baxter? Dr. Baxter, okay. So Dr. Baxter and I know publication bias all too well. He had 100 photos, measurements, the lip ties closing at the desk. I mean, he talked about this, right? You guys remember this? Oh my gosh, I had to go through 8 journals. One reviewer said, your data is thoroughly convincing, but I haven't treated one of these lip ties in 30 years. And also, if I accept this, my colleagues are going to think less of me. So, reject. Okay? I mean, the data is convincing. He's got photos, he's got measurements. What's this about? Time and time again. But we persevered, and we got it in the literature. And just getting your footing is huge. You guys have no idea. To get that article in means that they have accepted that lip ties might have something to do with something, and it opens the door for future research, okay? We have data on 1,000 data points with Audrey Yoon, tracking out the upper lip ties. We're going to be looking at lower lip ties with our affiliate centers, but really the only way that I would invest the resources of the Great Institute looking into that was if this article got accepted. So thank you, Richard, for persevering. Because this is what we have to do to kind of move things forward, all right? That's publication bias. 2 other things I want you guys to know about is performance bias and measurement bias. And again, the reason I want you guys to know this is that when these articles come up on Facebook, I don't want you to say this is a good study, this is a bad study, right? I want you guys to say, oh, this research is plagued by confirmation bias, or this article has performance bias or measurement bias, right? So let's kind of look at these terms that we're going to be focusing here on today. Performance bias means that the way I do a tongue tie release is different than the way they do the tongue tie release. Does that make sense? Okay? So Kaiser doctor does a tongue tie release, he calls it a tongue tie, he publishes that tongue tie doesn't work. What we're doing is totally different. Okay? So their research is troubled by performance bias. They're not performing it to the current standards. Are you guys with me? Is this helpful for you guys? And the other one is measurement bias. Measurement bias means that the way I'm measuring a tongue tie is different than the way you're measuring it, right? So a lot of these studies, they're taking patients with like grade 4s and comparing them to grade 3 and 2 tongue ties, right? Because they're not distinguishing between them. It's how you're measuring to determine whether there's a restriction there or not. And we'll kind of hone in on that a little bit as well, okay? Who here has seen this article? The SALT article on speech, okay? So, like we said, we're going back and, they published saying that tongue tie has nothing to do with speech, okay? And they said, look, we did all this research and tongue tie has nothing to do with speech. So I want you guys to know that it's not just the conclusion statements. The conclusion statements are plagued by what kind of bias? Confirmation bias, okay? In this article, they had 3 groups. Tongue-tied children, not untreated tongue-tied, and, treated tongue-tied in the first group, okay? TTT, untreated tongue-tied, and no tongue-tied, all right? And they say in the conclusion, right, that there's no evidence, let's see, let me read it for you guys, no difference between tongue mobility and speech outcomes in young children. But if you look at the data, the treated tongue-tied all have higher numbers than the untreated tongue-tied. You guys see that there? Okay? So the treated tongue-tied kids have higher scores than the untreated tongue-tied kids. Yet they're interpreting that as no difference because it wasn't statistically significant. Are you guys seeing this? What kind of bias is that? Confirmation bias. They're convinced that tongue-tied has nothing to do with speech. So even when the data is pointing one way, they're interpreting it another. So you have to, when these articles come out, what you're going to say is lack of evidence is not evidence. All right? That's what you're going to say. Just because you weren't able to show a difference, we don't know that maybe there's confirmation bias, maybe there's performance bias, maybe there's measurement bias, and the study, it's not going to be reflective of the true conditions. So I hope that you guys are appreciating how we're talking about these issues to empower you to help take care of the patients in your community. And you should also know that there's a rebuttal letter to the editor that speaks exactly to this, okay? So if anyone ever brings that article in front of you and says, where's the research, I saw this article, you let them know that we published a rebuttal letter that suggests otherwise, and that many of us here are doing the clinical research. We're actually looking, observing, to establish these relationships, not as opinions, but as matters of fact.
Wednesdays, because there was an AM and PM group. On Wednesdays, it's everyone, and there can't be too many people, and not enough desks. Airplane. Only. Stall, earphones, cereal, deal.
Or what? Yeah, but who here has seen this in their clinics? The same thing. Show of hands. All right. What power? What power? Amazing, right? These things are not surprising. We see these day in and day out, and we've done research on these topics, showing that if we release these tongue ties, patients have improvements in mouth breathing, muscle tension, snoring, clenching, and grinding. Dr. Baxter's written one, and it includes even speech, feeding, and sleep. So what's going on? Right? Why are they still publishing in 2021 that tongue-tie release does not improve speech articulation and intelligibility? We don't even show the article, right? But what are a few different reasons why this might have been published? Number one, confirmation bias, right? Okay, we got that one. What else? Publication bias. They like to publish things that are supporting them, right? What are 2 other things? Performance bias. Performance bias means, and this breaks my heart, I get these once a week, okay? And that's why I'm here today. I get emails from people who've had releases done in the local community. Do you guys know about the Kaiser system? All right? The Kaiser doctor did this procedure. And he said, here you go. And then she went to urgent care. And you know what they told her? Looks good. She's in terrible pain. She's worse off than before. This is not tongue tie release. We're doing the procedure totally different. So when someone tells you, hey, like there's no research, the research is showing this, we say, yeah, they're doing it very differently than what we're doing. And I agree with you. This isn't going to improve speech, right? Does anyone think that this procedure is going to improve speech or feeding or sleep or anything? So we're in agreement. But these cases breaks my heart, and I want you guys to leave feeling empowered to take on these cases, so they don't have to travel, 200 miles, 205 miles, take a flight to come and see me. Who here wants to watch us do this case here today? You guys think that'd be interesting? Okay. So let me show you before and after, and then we'll look at the case.
Look your mouth for me. Good. Lift up your tongue. Okay. You drop it down. Good. And do you want to tell us anything about your symptoms? Or?
I'm in pain all the time. Eating, speaking, yawning, hurts it.
That was before you got it released or for right now?
No, right now. So I had the surgery done 10 days ago.
Got it.
The whole neck closed and I got a white bump above it.
Yeah.
Went to the emergency room, they told me nothing. They were like, oh, you're fine.
And we're so, one of our colleagues sent you here, we're so happy with you.
Yes, definitely. Yeah, thank you.
All right, so I'm going to jump to the after, okay, and then we'll watch the procedure, okay? Here's the after.
I'm done? Oh, God.
You notice the difference?
Yeah, I can stick on my tongue.
That's right. Lift it up. Try not to stick it out too much because it's hard to breathe.
Right.
You don't try to stick it, okay?
Yeah, but thanks, Benny. There's so much tongue.
Better, right? Let's get in there, take a closer look in there. Not the very after, yeah. Lift up your tongue, lift it all the way up, reach it up. Fantastic. There we go. We're going to do some exercise and reach to the maintain, okay?
Uh-huh.
Any last words?
Thank you.
Thanks for giving us the opportunity.
Thank you.
Yeah, you got it. You got it.
So here she was before the procedure, here she is afterwards. And we'll be showing you like 4 different cases today. This is part of our deep dive series. So we have a library of 20 cases so far. We'll be adding 1 a month. And it'll be available online for you guys who are interested in participating. You can go through, you can study it, like the whole case, like step by step by step, giving yourselves a little virtual mini residency. And the cases include, go ahead and play it, right? Just the video themselves, but also a walkthrough. So I'm going to walk you guys through this case. We'll have it be interactive, all right? And I'll explain to you guys what we're doing. All right?
Good. Testing. And do you want to tell us anything about your symptoms? Or?
I'm in pain all the time. Eating, speaking, yawning, hurts it.
That was before you got it released or for right now?
No, right now. So I had the surgery done 10 days ago.
Right.
The whole neck closed and I got a white bump above it.
Yeah.
Went to the emergency room, they told me nothing. They were like, oh, you're fine.
And we're so, one of our colleagues sent you here, we're so happy with you.
Yes, definitely. Yeah, thank you.
So the first step is you put topical anesthetic on the tongue, whatever kind of anesthetic you guys want to use. I like 2% because it's lidocaine. You can also do like a prilocaine lidocaine mixture. All of you guys have different compounding that you like. You start that the first round. So this patient's already been topical. This is an injection. I start low, moving my way up. Okay.
Yeah, so you can see that it's bleeding because of that.
All right. When you go into a wound early on, within the first 2 weeks, there's more bleeding there. That's why, in general, we like to wait 6 months before we go back in for a vision procedure. In this case, this patient is actively having difficulties and trouble, so it's not right to wait 6 months. You guys agree, right? We got to kind of go into it. You have to recognize that that area has a neovascularization, new blood vessels that are coming to the surface. So if you touch into that direct area, it's going to bleed a little bit. Not severe, but just a little bit. You're going to feel this one, okay? All right, so the closer you go to the tip, the more sensitive it is. Make sure to inform your patients so they know and they develop some trust with you. The anesthetic does have a little epinephrine in it, which helps with vasoconstriction. Okay. Any questions about numbing? We're going to go through a bunch of cases. I'm also going to do didactics. Any questions as explained? Are you guys enjoying this so far? Good pace, or should I go faster? Good pace? Yeah.
She started as a grade 4?
She starts at grade 4, and then this is where they got it, right?
Yeah.
Did she have any myofunctional therapy?
Before, no, and not even before this, but after this, definitely. These are the exception cases, right? I gotta get her help. I can't say go do 2 months of therapy and then come back, right? But she gets into therapy right after, and I'm going to show you her therapy as well. All right, so what are we going to do, guys? Think it through in your head. What are we going to do? Where are we going to come from? All right, so the goal in these cases, when you have a 4, is to turn it into a 3. When you have a 3, you turn it into a 2. And then from the 2, take it to a 1. So I'm just trying to make incremental improvements. Close a little bit, see where I'm at, and then continue on, all right? So here I am, I'm going sideways along the sublingual worm's depth. Just a couple millimeters above it, I'm making a slight opening with the laser. In a second, we're going to talk about the different settings that we're using. This may be either mucosa or the fascia setting, all right? And I'll tell you about the different kind of settings in a little bit. But basically, it's just above the sublingual caruncle, 1 or 2 millimeters above it. I'm just going laterally. Here, I'm seeing that there's some thick tissue. What tissue am I about to encounter? It's not mucosa, not fascia. What muscle is that as you guys are looking? That's genioglossus muscle, okay? So this is a very thick tongue tie. She said that she bled a lot during the procedure. It does involve the genioglossus muscle. As we've learned, the fascia wraps around the muscle, right? As Nikki Mills has described, and that's what gives the tongue ties different morphological variability. Okay? So my approach is just to make a little bit of a hole, all right? I gained some success, I took that first step, and then you reassess and you take your next step forward.
Would you have made that initial incision if you had done this from the beginning, or would you be a little higher?
They were just in the tongue. They were too much in the tongue. They should have gone lower.
So if you had done this from the beginning,
I would have gone lower.
then you would sort of
Lower, yeah, in the frenulum. They cut into the tongue.
Yeah. I mean, higher than you did right then, or about the same?
Right, higher than what I did right here.
Yeah.
Yeah,
Right.
but lower than what they did.
Yeah.
Really well. We're really happy. Okay.
Did she have any lingual nerve damage?
She did not. Okay, you can go plus 10. Go. You guys enjoying this pace? You should pick up a little bit. It's a good pace?
Yeah.
Okay. Notice what I'm doing. When I try to get blood vessels, I don't go side to side. I go up and down. If there's a blood vessel there, why would you want to cut through it? Why would you want to cut through it? You go up and down, okay, and then it'll look this way. Much safer approach. Does that make sense? Right. Revision cases like this, there's a lot of unknowns. That's why I'm trying to use meticulous surgical skill. You guys see that I'm pushing on the tongue. Pushing on the tongue is decreasing the blood supply to the tongue. You see that it's a bloodless tongue. What muscle, what am I going through? Genioglossus, a small blood vessel on the side there. You guys notice that? I'll change it to the hemostasis setting. And maybe just kind of go all around or up and down. But definitely not back and forth straight through a blood vessel, right? We've come so far, I don't want to And there's multiple ways to do this case. I'm sure there are others out there who may approach it differently, but I think you can learn from the way that I decided to approach this case and see, would you do it different or similar? All right, so going a little bit deeper here.
When you see yourself getting into the genioglossus, do you then automatically just give more anesthesia?
I give more anesthesia when I do genioglossus muscle, absolutely. I'll tell you why. Great question, all right? First of all, you don't know what's behind the genioglossus muscle. Is there a major lingual artery there? When you inject, right, first of all, you're getting anesthetic to that area, but second of all, when you withdraw, it'll either be dry or it'll bleed. If it bleeds a little bit, you lose a small blood vessel. If you put your needle there and it bleeds a lot, then you know that, uh-oh, maybe I need to be a little bit careful, okay? So whenever I go to the genioglossus, I inject a little bit, I put my needle in to kind of see is there a blood vessel there, and if there is, I'm more judicious with the depth of my release. Okay? All right, now we're doing much better, right? Okay? We're still not done. There's some genioglossus muscles there. The genioglossus muscles are protruding through the ventral surface of the tongue. Are you guys seeing that? For those who take my course, it's sticking out. I take the genioglossus muscle back until it's smooth with the ventral surface of the tongue. Does that make sense? Yeah, and keep the comments coming, it's helpful. Is the video going at a good pace still?
Do you only use a laser?
So I used to use only scissors, okay? I didn't even believe it, but I looked at my records. I used to use scalpel, okay? And I'm going to show you my scalpel case. And you're going to see the difference today, okay? I could barely look at it. Then I did huge scissors, okay? Like these gigantic scissors. And then I got smaller and smaller and smaller, finer scissors. Now I do scissors or laser. My preference for the muscle is definitely laser. Definitely laser. My bleeding rate used to be 12%. Now it's like 0, 0. Like I don't have any bleeding complications with access to the laser. And we now have 200 data points. Peter's been pushing for this for a while. Where's Peter? Is he here? Maybe you stepped out. Peter? No, he stepped out, but he'll be happy. You let him know that we have 200 data points showing that access to a laser, not using a laser. You don't have to use a laser for every case, but having access to it can significantly drop bleeding complication rates. There are times where I prefer the scissors. Some patients don't like the smoke of it, okay? Sometimes I just want a quick cut. There are specific circumstances in which I might prefer to use it, but the laser works really well. The scissors also works better for identifying the underlying anatomy and for teaching, so I will show you a recent scissors case as well.
Is this a similar technique if you're doing a child? Is there a lot more tissue for an adult?
So every case is different. Every case is different. Children tend to have less of the fascia trapping the muscle. The older you are, the more fascia has penetrated the muscle. So it's less likely, but there are some cases like Dr. Pinto showed where it's like really thick and it's already really well trapped. Does that make sense? All right, looking good? Notice this, okay? I'm not dissecting upwards into the muscle. As the muscle releases up, I gear my laser more and more down, okay? I'm always operating down. The muscle's sneaking up, I'm going lower and lower, like you're peeling an orange. You see how I keep pointing it downwards? It goes up, and I get it down, and it goes up. Notice that I'm providing countertraction in this case. This is still a good pace? Should I speed up a little bit? As I'm doing the procedure, I'm thinking about how I'm going to close it, all right? I'm kind of keeping that in my head. How am I going to close this? Where am I going? If I'm not sure, I might start the closure and then continue on as well. Okay, in this case, we are experimenting with different types of sutures. We have photochromic suture and PTFE suture. Photochromic suture self-dissolving, right? How do you think it self-dissolves? Through inflammation. The chromic absorbable sutures are going to be more pro-inflammatory than PTFE, for example, all right? In this circumstance, since there's already a lot of inflammation, I don't want to add more inflammation to the tongue area. I'm choosing to use the PTFE suture. Who here has heard of PTFE? Okay, you guys like using it in oral surgery? Anyone? Have good experience with it? There's pros and cons to it. The PTFE is less inflammatory, but if there's a lot of tension on the wound, the PTFE will not tear. It will slice through the tissue. Does that make sense? So if it's a high tension wound, PTFE will slice through it like a guillotine. And it's maybe not the best choice. PTFE works better when you want minimal inflammation and it's a low tension wound. Any questions about that? Are you guys learning anything today? Are we doing the black diamonds? You guys with me?
The area above that kind of a fascial area at the very top, that's actually in the tongue.
That's in the tongue.
And did they?
They were in the tongue the whole time. They were not doing frenuloplasty. They were doing tonguoplasty. Yeah. Kind of breaks your heart, doesn't it? These things make me sad. Like I'm with my wife, and then I get these messages, and it like breaks my heart. Like it's like, why? But I hope that you guys might be benefiting from this.
Is PTFE silk?
PTFE has a similar feeling to silk, but it's not silk. It's not dissolving. If you do it narrow, all right, it'll de-epithelialize and come out on its own. If you do thick bites, then you have to cut it out. If you do thick bites, you have the risk that it'll guillotine the tissue, it'll slice through it. So we're trying different ways. I probably do 5% of my cases with PTFE. I have a discussion of the risks and benefits with the patient. All right. I've had a few cases. The doctor flew out. I said, hey, these are my two choices. Like, which one do you prefer? He's like, I'll go for the PTFE, but it sliced through the tissue. Okay. So when you're the first of a new technique, you might benefit from it, but you might also kind of wait for what the research says. So, limited experience. What do you guys prefer as suture material? Who here is suturing their cases? Okay, fantastic. Love seeing that. All right. Who here is using chromic suture? Who here uses PTFE? Who here uses something else? What do you use? Silk. Does that work out nicely? Does it not cut through the tissue? Probably doesn't, right? Yeah, probably silk doesn't. How much do you get much inflammation? And which size do you use? 4.0? 4.0. Yeah. Silk is a good thought. So I'm gonna try a couple silks. Okay. Not bad thought. I would say silk is in between the inflammatory profile. It has braids on it, so food can get trapped. And when food gets trapped, it can make more inflammation. But silk is a good option maybe for high tension wounds, maybe more in the middle than the chromic. Is this making sense to you guys? This is really high level, right? All right. We start closing from the bottom here. What's that?
I was going to ask, how do you keep the sutures from popping out? Like mine always pop out like right
You're
now.
not squaring them. You have to square the knot. So squaring the knot, look it up on YouTube.
Okay.
If you're not rotating your hands correctly, then you haven't really thrown like an actual knot, it's like a slip knot, and it's just going to slip off. So if your sutures are popping off, you're probably not doing a square knot. So go on YouTube, practice. Yeah, go ahead, Lily.
I was going to mention for anybody who's interested in more suturing techniques, it's a 2.5, almost 3-hour portion of the brief course. We walk you through suture training as well.
Yeah. And then for those who take the affiliate proctorship, we practice one-on-one. So you come and I look over your shoulder and you throw it and I'm with you. I say square, right, left, right, left. Any skiers in the group? Yes, right? Yeah. Love it. Okay, so this is called the butterfly technique, the way I'm holding the tongue, okay? I'm pushing on the two veins on the sides, and really kind of exposing, opening up that wound. Are you guys good if we go a little bit faster, or are you guys enjoying the section? A little bit faster? Okay. You'll keep it? What's that? I have so much to give you guys, that's all. But I'll play this one. I've only got 3 hours today. They didn't have enough time for me.
That area where they pen the tongue, are you going to suture that?
I'm going to suture closed. I'm going to suture closed. Yeah. Okay. Less and less. Less and less. So 3 different types of sutures. Simple interrupted. At the base, if it's high tension, I love the figure of 8. Figure of 8 is like 2 simple interruptions and then you tie. Horizontal mattress, if the tissue is tearing, it's high tension. The simple interrupted has a tension across the wound. The mattress is on the edges of the wound, bringing it in. So the mattress won't tear as much. Does that make sense? All right. Let's go plus 10 seconds. Where's the... you're going to fast forward a little bit for me? And just push 10 seconds, and then I'll tell you. Just push one at a time. Just one at a time. Yeah. There's a mattress. You guys see that? Go back. Go back. Go back. Okay. Let's just play this part. So I'm about to do a mattress here. The reason I'm doing the mattress is when I throw that light, okay, I feel the tissue's going to tear there. Do you see that? The tissue's about to tear. So if I tie it there, it's not going to hold. So I go back and I spread the tension along the sides of the wound. So up here, the first throw I did, I felt like if I was pulling it, it's going to tear. So I come back down below it and carry through. Make sense? No questions? Look here, as I tie this horizontal mattress, it's on the side of the wound. And if it's not clear, type in, again, horizontal mattress into Google and why it's used, and hopefully it'll become more clear. That'll be the learning point for you guys, okay? All right, go ahead and go plus 10 seconds. And again, for those who sign up for the deep dive, you can go, you can do this in slow motion, but I kind of want to get through the case, okay? Go plus 10 seconds. Here's another mattress. What's that suturing? Sometimes. Yeah, sometimes. If I don't know how it's going to end up, if there's a lot of tension on the bottom, you try to tie the bottom, it'll just open up. So sometimes you want to start in the middle or in the top. Every case is individual. You can find your kind of flow and technique. Okay, another mattress there. I don't want the tension on the wound, especially in that area where they bovied it or whatever. It's not really healthy tissue. If I tie down onto the wound, you're like strangling the wound. Does that make sense? So I'm bringing it in from the sides together and not strangling the wound. Is that concept clear? You want to repeat a different way, Hal? I think you understand. I don't think I'm getting clear.
No, it does, because I look at it as you're gently pulling
You're gently pulling the edges together rather than squeezing the middle and pushing it down.
Like if you have 2 curtains and you pull them in with little rods.
Yeah.
And if you tie the rope between.
Exactly right. 2 rods, bring them together rather than 2 ropes. So you can do
Little
it.
curtain analogy.
Yeah. All right. Go plus 10 seconds. Okay, I think that's the case. Let's see. Is there a dog ear there? Waiting one more suture. Yeah, no big deal. You get the picture. Go ahead and plus 10 seconds. All right, plus 10 seconds. Advance it. Thumbs up. We're good in this case? Okay. Are we done treating her? No. We've just begun treating her. What's the next step? You can stop transitioning. Thank you so much. All right. You did the procedure. Are you done?
No.
See you in 2 months? See you in a year?
No.
What's next?
Myofunctional therapy.
For this patient, when are you going to see her? 3 days. This patient? This patient, you call her the same day, right? How you doing? It's a traumatic case. Keep in mind, the patient's level of anxiety, all right, will affect your wound healing. If you have a highly anxious patient, they're going to get more pain and more inflammation in that area. If you can call them and let them know that it looks great, it looks good, you're doing well, their anxiety comes down in that early period, your pain, your results will be much, much more superior. Just letting them know that they have access to you, calm their anxiety. You guys feel the same way? Wouldn't you feel that way if you were having a procedure? All right, so here she is, I think. So I called her myself. I think Perea, our therapist, called her 3 days later, and this is 1 week post-op.
Hi, Dr. Zaghi. This is Stephanie Duffy. It's been about 10 days since my procedure, and I thought I'd check in and let you
How's your speech?
know how I'm doing, how things are healing, and just let you know everything's going well. So pain-wise, there's no more. When I first went in, I had like a giant hole in the bottom of my tongue, and the tip of my tongue felt like it was on fire. No longer experiencing any of that. So that's wonderful. We had stitched my tongue up, and a couple minutes later, one of them had kind of come open, and of course I panicked, but I was assured it was okay. And just to show you, the rest of them had stayed in, and there's no longer a giant hole in my mouth.
So she's not able to lift her tongue up. You guys seeing that?
Nope. So I started my physical therapy. I had one session. My second session is scheduled for later today. And I just wanted to share with you a couple of the stretches that I've learned that have really helped me. The first is you take...
Okay, so we're going to watch this in a second. Okay, so you got it. You got to use it or lose it. Okay? If you're not moving your tongue, if you're not able to, it's just going to scar back down. Do you guys agree with that? Okay. So what we teach them is manual wound stretches, and she's going to demonstrate a few here. And then we go through this extensively in our myo courses and wound courses and my
grab the tip of your tongue and pull it out. And once you feel the stretch release, you count to 10. Then you pull your tongue to one side and count to 10, and then to the other side and count to 10. So.
Yes, please. So it's not going to contract in the first 3 days. Okay? So definitely by day 3. The first 2 days, moving the tongue can help take up some of the swelling and inflammation. So you have to use your judgment. If it's a low-tone tongue, earlier is definitely better. If it's a high tone, you know what I'm talking about? High tension, if it's going to break through, take it easy. Does that make sense? Every case is individual.
Stretches like the back sides of the tongue. So you start off with the hook, and same side, same hand. You put it in under your tongue, turn your hand, flex your finger, and then push up. The first time I had done this, I pushed a little too hard and kind of hurt myself. But my physical therapist, Mariah, told me it was okay to be gentle, that there's no reason to force my tongue any further than it wants to go. So, hook. And 10 times on one side, and then 10 times on the other.
And where's Sanda?
That one really helps me.
Sanda? Okay, so we thank Sanda for these stretches. Actually, stand up, Sanda. Yeah, round of applause. And it turns out it was her birthday, so happy birthday. So our myofunctional therapy protocols are always evolving. Always evolving. They do research, I make them collect data, we're evolving it. It's fine if you're taking other myofunctional therapy courses, but if you want to learn the brief protocol, we have online programs, but also this year we're going to have an in-person, hands-on, okay? So as many videos as you watch, okay? You can watch a million videos. The really way to learn it is to have Sanda there, showing you, one of our therapists there, pulling the tongue, feeling it, trying it on a partner. So if anyone interested in an experience like that? Yeah. Okay, hands-on, okay? So at the end, I'll give you guys an opportunity to, okay, so that's the case. So at the end, I'll give you, we'll do it now actually. Okay. So if you're interested in, just go ahead and do the QR code here, okay? Just kind of keep this. Depending on what you're interested in, we make our educational programs tailored for your needs. If you need something online, we do it online. If you want, brief baby, brief kids, brief course, we're going to have an online brief course. If you want to come shadow me for a day or two, okay, these opportunities are available. If you want me to come out to you guys, if you want myofunctional therapy, if there's something that we don't offer yet, please reach out to us. Is that the deal here?
You have to leave early.
You have to leave early? Okay, so we're also going to be having some expansion courses and things like that. So a lot of opportunities, always evolving, and the goal is to, help you progress in your skills. All right. Did you guys enjoy that case? Do you guys want to see more of them?
Yeah.
All right. So let me guys, let's go back. Okay, so that was that case, okay? So where's the research? I hope you guys have all seen this article. Yes? Lingual frenuloplasty with myofunctional therapy? Everyone seen it? Raise show hands. Okay. So the technique, performance bias, right? This is not frenectomy. This is not tongue time release. This is frenuloplasty with myofunctional therapy. It's part of it. If you're not doing the myofunctional therapy, don't think you're going to get as good as results. Even so, the first 350 that I did, very transparent. I had bleeding 12%. Okay? And I'm telling you guys, this is how I first started. All right? And I went through a learning curve. And perhaps, the most difficult part of getting started is the fear that you're not an expert yet. And you have to recognize that the first one you do, I hope, will be the worst one that you do. I hope that you get better year after year after year. So don't let that fear of needing to improve stop you from getting started, okay? And no matter where you are, no matter what expertise level you're at, please recognize that we're always evolving. Where are our affiliates in the group? Is Dr. Stewart here? Do you have any other affiliates? Dr. Santos, okay? So a lot of folks, without thinking away your age, how long have you been doing dentistry and bioaesthetics? Dr. Lee? Yeah. How long have you been doing tongue releases? 2 years, Dr. Stewart. Dentistry, bioaesthetics.
32 years.
32 years, okay, and an instructor of bioaesthetic rejuvenation. Come to learn more, okay? Even myself, when I go and I watch someone else, I'm there to learn. Like I was with Richard in a course of some guy who's telling us how to assess the nose with rhino vision. Very interesting. I don't know anything about this. I'm here to learn. I'm an ENT doctor learning from a dentist about how to evaluate the nose. Why not? Open your eyes. Maybe you see a different way than I do, right? You got to be open to that possibility. And it's with that I appreciate Peter has been evolving the light scalpel and the settings, and these are the recent settings that we're using. Okay. So the purpose behind all of this is that there's different tissue in the tongue, right? Some of the tissue is mucosa, sometimes it's fascia, sometimes genioglossus muscle. And it doesn't make sense that you use the same setting all the way through. So we have settings specifically for the mucosa, settings for the fascia. The fascia is just more like cutting. If you use too hot of a setting on the fascia, it pulls the fascia in and it tightens it. That's why you can't get as crisp or clear of a study of anatomy, and that's why I tend towards preferring the scissors. But when you use the fascia setting, it's minimal on the coagulation, minimal on the hemostasis, and it tends to preserve the fascial architecture. Does that make sense? Fascia has water in it, right? If you dry it up, you're causing fascia restriction. So take a look at these settings and consider implementing them. So before I did my first tongue release, I did head neck surgery residency, okay? I did a fellowship at Stanford. This is how I got started. This is when I was an egg. Dr. Guillemino invited me on this paper showing an association of tongue tie with sleep disorder breathing. And then that was it. There was no more mentorship available. So Dr. Lou, Audrey, and myself, we developed a research team to take a look at how we're going to measure these and how we're going to treat them. The way that I started doing this, and I'm telling you, out of my humility to help encourage you guys to get started, was putting adult patients under general anesthesia in the OR. That's standard of care at Stanford. General anesthesia, okay? Using a scalpel technique with video myofunctional therapy. And the results were okay, but not great. So then Sanda and I paired up with Leila Chad's directorship and mentorship and support to study this, to do a research project. And so this is like my postdoctoral, thesis on the myofunctional technique of frenuloplasty. And we studied it, how deep to go. I went to cadaver labs to the point where we got really, really good at it. And we followed these cases up. 3, 4, 5, even 6 years. Some of them, 6 years later, are solid, okay? Healed really, really nicely. This is 4 years later, okay? Let me show you how we're assessing the results of our tongue-tie releases, okay? So, grade 1 tip, you guys all know tip, right? Okay? LPS, and floor of mouth hold. You guys see the floor of mouth hold? Show of hands who's familiar with tip, TRMR. Who here knows LPS? Yes? A little less familiar? Who here has seen floor of mouth hold? Okay. Floor of mouth hold, our research is going to come out 200 data points. That's going to be the real kicker in some of these like grade 1s and 2s. So the deal is, if you have a real tongue tie, you have a real tongue tie, okay? Like it's tie. If you don't know, if this patient's coming in and saying I have this issue, I have that issue, you don't know what it is, the floor of mouth hold is a good assessment to perform. So what do you guys think here? Is she restricted or unrestricted? Come on, restricted or unrestricted now? Unrestricted, clear, right? Okay, great. Here's Anna Gross. You guys met Anna Gross yesterday in Dr. Pinto's course, all right? She was one of my first patients. I graduated fellowship June of 2016, okay? I did Anna's release June of 2016. She was one of my first 20 patients, all right? What do you guys think so far of the picture? Looks the same, doesn't it? All right, so I did the procedure, but 6 years later, she still has the floor of mouth elevation, maybe a little less tension. Are you guys seeing on the screen? Okay. Is it good? Is it bad? Do we go back? She's an amazing colleague, okay? She's part of our Breathe Babies and Kids with my wife and Dr. Pinto, and she was humble enough to allow us to learn from her case, all right? So let's just see, this is 6 years post-op.
Hi, Anna. All right, so we did the procedure about 5 years ago. We're going to follow up. We've learned a lot since that time. Let's take a look, okay? Okay. Open up your mouth for me. Good. Lift up your tongue. Okay.
All right. So what do you guys think TIP?
Suction hold.
All right. So what do you guys think? What grade is she TIP? Say it loud. TIP? 1 or 2, right? Compensation. That's good. With compensation. Her LPS. What do you think? Above 30, like a 2, right? Okay. So for these 1-2 cases, like you're not sure, like, is it not? She's still feeling issues. That's when you do the floor of mouth hold.
Lift up your tongue.
Okay, and when you do the floor of mouth hold, I'm going to show you like a bunch of cases, all right? You're looking for a dimpling in the back of the tongue, a cupping in the back of the tongue, diminished range of motion, or fasciculation. So you guys can see that it's a little bit shy, right?
Yeah.
Questions? Any questions or comments? You want to see it again?
Not stretching it when it's swollen. And I think we would all do things differently this time, but luckily nothing too severe, and I'm looking forward to even more progress and improvement.
Did you have any improvement initially, or what was your experience like when you went through it like years ago?
Yeah, I mean, initially I did definitely have some decrease in neck tension, but it's since come back. So I definitely had an easier time working on my swallow, just sort of improving my tongue thrust. Now I feel like my function's really good, but I still have the residual tension.
And when did that come back? You know, a few months later, or just like years?
It's a great question. I think I was really optimistic about it for a long time, so I think probably, probably like 3 to 4 months later.
3 to 4 months later.
Yeah.
Okay, so she had the relationship damage for a couple months, and then it retethered. You guys heard that? Okay, listen to like the questions I'm trying to answer. I know that it's not great. I don't know how or why, but now we do know why she didn't heal well. Can you guys guess why that is? Any guesses? She's a myofunctional therapist, speech therapist. She did her myo. Okay, this is back in 2016. She was doing caves. Okay. Why? What's on her differential? Why didn't this heal well? What's on your differential diagnosis for why this didn't heal well? Tongue space. Okay? Tongue space. I know I've said it before. Tongue tie, tongue space, right? What is your tongue space? 31 millimeters intermolar width. All right? If there's not enough room in the mouth for the tongue is being squished on itself. You're not able to open your mouth to have that range, and the results are going to be suboptimal. Who here has seen this in their practice or here? Yep. Okay, so we're talking about a ton of space. Here is this is the first time I made this slide, in terms of when you should and shouldn't do it, like concern, okay? So ideal, 38 to 42. Most patients you see are going to be 36 to 38. In my opinion, that's okay. Go ahead. Go have the tongue tie release, no problem. If you're 34 to 36 millimeters intermolar width, you must have a discussion with the patient. You must tell them, you have a tongue tie, but you also have a little tongue space issue. Let's see which one do you want to do first. If they say, I understand I have a tongue space issue, but I want to do the tongue tie first and follow the ortho second, that's fine, you take the case. But you have to have the discussion, right? Because you know this is a risk factor. I'm telling you, you're at this conference. You have to tell them, hey, it's a tongue space issue, but we can still go ahead and then see afterwards. If you're 32 to 34, you really have to have that discussion with them. If they're less than 32 millimeters intermolar width, unless they're a severe 3-4, I wouldn't recommend doing it. If you are doing it, you're telling this is a stage 1. Does that make sense? So if you're like 32 to 34, you can do a stage 1 in anticipation of a stage 2 later on. But don't think this is going to be the last one you've ever had. Once they make the space, you have a centimeter more space. The tongue needs to have, it's going to look restricted again. Am I making sense? Do you guys agree? Do you guys feel differently? Okay. Well, I'm not trying to deny patients of care. If you have a severe grade 4 and a narrow mouth, all right, have that discussion with the patient, see what you want to do first. Maybe you release it, and then, like Anna, for example, we released it. All right, you're going to get expanded. We're going to go back and do a stage 2 later on after you're expanded. Clear? Questions, comments?
Is this same for like school age kids?
No, school age kids is 24 plus age. Okay? So what's normal intermolar width for children, right? That's what you asked. So it's the Bowditch index, and it's 24 plus age. So if you're 18, it's like 42, right? So if you're, if you're 6, it's 30 millimeters, for example. Did I say correctly, care dentist? Or kiddodontist? Yes? Okay.
Soroush?
Yes.
So you get a more rare case.
Sorry, one second. And then kids are different, okay? Kids, if you get their tongue up, it'll start to expand, all right? If they have a very, very high arch palate, you can't even do therapy, maybe expand first. I have not seen a kid get worse after frenuloplasty. I have not seen that. I have seen adults. 1 in 10 adults with limited tongue space do worse. 1 in 10. Not all of them. 90% of limited tongue space do just fine. But the 1 out of 10 with the narrow airway, it kills you. It's like emails and it's just like terrible outcomes. Yes, please.
So that, well, now I have another question. So
Yes, please, I love it.
when you say, about what age are you
So children, like pre-pubertal children, okay, like they're going to do great, okay? The therapy might be limited if they don't have enough tongue space. Your results will be better if you have the tongue space, but don't deny a kid like a 3 or 4 tongue tie. If it's grade 3 or 4, release early. If it's grade 1, 2, compensating all this, maybe expand first and then release. But use your own judgment in your own situation.
Okay, my original question. So you're looking at your intermolar width on those more rare cases where you may have a nice intermolar width, but on the CBCT you see a
Posterior, yeah.
Posterior,
Yeah.
retroglossal
Yeah.
space.
In that circumstance, it's difficult. I don't have a great answer. Okay. What I would do is I would do a sleep study. If they don't have sleep apnea, you're going to be okay. If they do, this is pre-preview. I'm trying to get to 100, right? I only have 60. So I have 60 pre and post I'm trying to recruit. If you don't have sleep apnea, you're probably going to be okay. If you have sleep apnea, I would really hesitate. Yes? Instead of Malapati, we're doing lingual palatal suction and seeing the mouth, and I will show that. I can jump that there now, but I'm definitely going to show you guys the whole thing. So if you do a suction hold, you look for tongue overflow. Malapati is you sticking your tongue out, like maybe, it's really hit or miss. Other questions, comments? Yes?
Just kind of a follow-up to my first question. I know when we take CBCTs, we only instruct the patient to have the teeth close together. But in a case like we were just talking about, if they've got a nice palatal width and you take the CBCT and their tongue is down, but they are able to hold it up for some, enough, long enough to have a CBCT. Would you take another one with their tongue in their mouth and then see what the retroglossal would be?
It's really a judgment call. It's really, all these are like judgment calls. There's no hard or fast like rules to it. You can do that. The hard and fast rules that I'm kind of putting up are kind of on this slide, that this is how much you should be concerned, just so that you're familiar with. But I myself will release patients if they're narrow and they have a grade 4. At 32, I'll do it. I'll make that decision. But you have to have that discussion of the risk and benefits and have thought it through specific for that case.
Yeah.
Does that make sense? You guys feeling updated? It's the first hour. Should we do a couple of couples? You guys still, anyone want to continue or should we call it? Should we continue? Yeah, you need some energy? Woo! Yeah, all right. So, who here wants to see Anna's case? I don't want to see it either, but let's see it. 6 years ago. I'm using a scalpel, guys. My eyes popped. I couldn't believe it. I forgot. Look, it's like hemorrhaging. And then my big deal. I couldn't handle this anymore. Yeah, I had just finished training, big surgeries, like tongue reconstructions. So this was like nothing to me then, and now it's like, look at these giant scissors that I'm using. Where did you get them lately? Office Depot? 280 scissors? Like, office envelope scissors? I'm holding pressure. Everything's fine. Under control. We have a great result. But notice even if it is bleeding, right? You reassuring the patient is going to bring their heart rate down, bring their blood pressure down, okay? Put the tension in the uterus and move things along, okay? So you have to make sure that you're calm yourself.
Soroush, I noticed in the case before you didn't do the blood dissection in that. Maybe you did, but you didn't go.
I think I didn't in that case, yeah. There was inflammation about it, so I didn't want to ruffle it. So similar, but also different. What's that? It was more bleeding, yeah. And when I published it transparently, 13% bled for 1 to 2 days later.
But it's cool because it still got really good results.
But it still got good results though, right? Yeah. What's that? It's a case-by-case situation. The answer is going to be until the range of motion is improved, okay, 4 mouth hold, and until the fibers that you're seeing are kind of freely moving, and it's underneath the ventral surface of the tongue. The genioglossus muscle pops out, then you're going to develop scar tissue. It's not going to heal up. So very little, but enough so that it doesn't scar and it's out of the way and it's back to its normal place. Keep in mind that the fascia pulled the genioglossus muscle into it. You're not trying to shave off your genioglossus muscle. You're just trying to release enough so the genioglossus muscle goes back into the tongue. Genioglossus does not belong in the frenulum. It belongs in the tongue. You're just trying to replace it, put it back where it belongs. Does that answer your question? Dr. Christensen? Okay, I learned echo vision from you yesterday. Great presentation. And, really enjoyed it.
Amazing.
Oh, I mean, this is some confirmation bias, right? All right. I mean, it's still bleeding, that's why the gauze is there, right? Should we fast forward to this case? What do you guys think? Okay, go plus 10 seconds, yeah. Plus 10 seconds. Okay, starting to close it, I think. Yeah, go plus 10 seconds. Go ahead. I got much faster at the suturing myself. I just want to show you my early case to kind of inspire you guys to tell you that, hey, with practice, like I've done like 2,000 since, and I've watched other people do several hundred. You're going to get it. You're going to pick it up. Go plus 10 seconds. Thank you. And plus 10 seconds. Yeah. Back to the scalpel? What are you doing? Oh, just start from the beginning. Okay, so then you start from the beginning, right? All right, you guys get the picture. Okay, so we'll go back to the lecture. All right, interesting for you guys to see? Yeah? All right, so now we're talking about, it's not only about tongue tie, it's also about tongue tone and tongue space, okay? So let's go through our 5 dimensions of tongue tie diagnosis. This will be pretty quick, but stop me if you guys don't understand, and we'll go more slowly. The first dimension is cautelobe-free tongue measurement. Everyone understands this one, yeah? This is, can you stick out your tongue? Can you stick out your tongue 16 millimeters? Is the free length of the tongue, the position of the frenum, more or less than 16 millimeters? All right? If you're less than 16 millimeters, obviously you're tongue-tied, but there are many that are 17 millimeters that still have a problem. Do you guys agree? Okay. So we recognize that cautelobe-free tongue length 16 millimeters is a good start, but it's not quite enough. There are many patients who, despite being able to stick out their tongue, cannot lift up the front of the tongue or the back of the tongue. We assess anterior tongue mobility, the front of the tongue with the TRMR-TIP measurement, the back of the tongue with the LPS measurement. All right, here's this patient's sleep study showing what a great result he got. This is the TIP, and again, I know I'm going fast, okay? I do have some of this content online, but if you want to go through it slowly, like the beginner course, I encourage you guys to take the brief course or watch one of the online videos. This is intended to be like a high-level update overview. Is that okay? Okay. So everyone knows TIP, tongue papilla? Okay. This is LPS, lingual palatal suction. We actually came up with this term. We polled a Facebook group. We said, what should we call it? And now everyone knows LPS, right? How amazing. We didn't have LPS 2 years ago. We called it something else. We called it like tip mawa or something like that.
It was like M-O-T-T-I-P. Like
M-O-T-T-I-P. I bet that's
opening tip of tongue up or something.
Yeah, something like that. Yeah. So we want the whole tongue up in the roof of the mouth. You take the comfortable mouth opening and you compare that to the tip of the tongue up in terms of interincisal mouth opening measurement. Our initial paper describing this was published in 2016. Since that time, this paper is outdated. This paper should not be cited. Instead, this paper should be cited, the 2021 update, which includes the original TRMR, but has the more appropriate wording and language, okay? This one's going to talk about Mo tip and Mo wows and all these confusing things that we have since updated into this paper that describes ranges for the tip and LPS. And this is talking about tongue mobility and describing that tongue mobility can be affected by different factors. What are some factors that can affect tongue mobility? You guys tell me. Tongue tie? What else? Tongue tone and tongue space, at the very least, okay? This paper establishes the definition of functional ankyloglossia includes problems with tongue tone and tongue space. Is that clear? Okay, so you can have a freedom restriction or you can have a problem moving your tongue. Ankyloglossia is a problem moving the tongue. The tongue's not moving correctly. It's curved. It's a bent tongue. Well, you can have problems with tongue mobility due to freedom restrictions, but also myofunctional issues and orthodontic issues. Questions, comments about this? Okay. So we've provided ranges. I have a whole lecture on it. The takeaway point is that you should be able to lift up the front of the tongue more than 50%, ideally closer to 60%, and you should be able to do lingual palatal suction more than a third of mouth opening. So is this restricted or unrestricted? Restricted, right? Okay, obviously restricted, and here we go unrestricted. You guys good with that? Okay. Nevertheless, this is what we're going to focus on. There are compensations. Compensation means that you're lifting up the tongue, but you're doing it at the expense of the floor of mouth, neck, and jaw. I think you guys all understand compensations. Yes? Show of hands? Yes? Okay, great. So this patient is compensating by using her whole entire being to lift up. How do we assess for tongue mobility in patients with compensations? I put it out to the universe, and this patient came to me, and this is how we discover floor of mouth hold.
So without the appliance in, I can do this with my tongue. And with it in, I can only do this.
So when the appliance is in there holding down the floor of mouth, she has diminished tongue mobility. Maybe if we hold down the floor of mouth, we can better appreciate trying to control for the compensation.
Here it's affecting my speech probably much more than the top appliance did because it's restricting my tongue so much.
Great, okay. So we've come up with this maneuver, okay? It's the floor of mouth hold maneuver, and we're about to publish 200 patients who've had this done before and after the release. I'll show it to you guys 1 second here.
Lift up your tongue. Lift up the tongue to the front 2 teeth. Okay. So you can see that it looks like a grade 2 tongue mobility, but really she bring up her entire floor of the mouth. And if we hold her floor of mouth down, where it should be, and ask her to lift up, you can see she can't get it up. She just cannot get up the tongue. You see the dimple right here that reflects the side of the frenulum attachment point.
Okay, are you guys seeing that? The cupping? Okay, so this is the point that I'm trying to make here today. The floor of mouth hold maneuver. You're going to put one finger onto the sublingual caruncle, push down, so that the floor of mouth is down instead of kind of pushed up beyond the gluteal surface. Who here has heard me talk about this before? Right? I'm talking about like 4 or 5 years, right? Just this year, Moon published showing the validity of this, so he validated my initial finding, right? That's how science works. I put something out there, hey, this is interesting. Someone else says, yeah, that actually works. So what he did is he's assessing for posterior tongue ties using this maneuver and showed an association with posterior crossbite, such that if you have limited mobility of the posterior tongue, you're more likely to have problems with the maxillary arch. Let me show you a normal example.
And now we're going to demonstrate an example of ideal or normal tongue mobility. And we have our tongue model here, Jen. So Jen, go ahead and open your mouth as wide as you can without pain or discomfort. All right, now lift up your tongue up to the front 2 teeth. Very good. Now suction up for me. I'll show you your cave. Excellent. We don't really see any compensations here, but if we want to control for them, we can use this group director. And so go ahead and open up your mouth. And I'm just holding down on the floor of the mouth here and noticing that it's not restricting the mobility of the tongue. Very, very good. Show me your cave.
Okay. You guys can, so let's see a few cases, okay? We'll go through these quickly, but if you guys want to go some more slowly. So this patient, grade 3 tongue tie, obvious, right? You guys agree? Restricted? All right, let's try the floor of mouth hold on him. It's almost not necessary.
Good. Relax everything. Open. Lift your tongue up. Okay. Okay.
I'm showing you multiple cases so you can get a feel for how I do it. Is that clear? Mm-hmm. Is it helpful? Do you guys want to see a few cases quickly?
Yes.
Yes?
Yes.
All right. So here he is before. Here he is after the release.
Up to the front 2 teeth. Good.
So he still has some compensation there.
Very good. Drop your tongue. Open up. Lift up your tongue. Terrific. Up to the front 2 teeth.
All right. So that's one of my endpoints for a release. I want to make sure that they're released and they can get up the tongue. Questions, comments on that one? All right. This is an example of black or white, right? It's obviously restricted at first and then it's functional. But the truth is that there's a wide range in real life. And what we're doing in our research is looking for change to the range of motion, the visible cupping of the dorsal surface of the tongue, that dimpling, weakness or fasciculation, as well as recruitment of the jaw or neck muscles. Let's show you another case. This case, it's more like so-so, like, seeing the pediatrician, is it a tongue tie, is it not a tongue tie, what's the issue, what do you think? So doing the floor of mouth hold can really illustrate the restriction.
Good, good video. Now lift up your tongue. Good. And do suction hold. Good. Drop your tongue down. Open up your mouth. Lift up your tongue.
You guys seeing the restriction now?
Uh-huh. Good.
All right, and here he is after the release.
Good, good video. Now lift up your tongue. Lift your tongue. Good. Do suction hold. Good. Very good. Open big. Latch your tongue down. Open your mouth. Lift your tongue up.
You're back in arcade.
Tongue up.
What's that? It sounds like he's just watching a show or something like that.
Lift your tongue up. Lift your tongue out. Okay, well.
Okay? Is this helpful for you guys? Okay, so let me show you another case. What do you guys see? Do you guys see the floor of mouth elevation here? Okay. Let me give you a little tip or a trick, okay, for this case. You see how tight that band is? You see how tight it is? All right, so here's like an insider's trick. If you want her to feel a fascia release, you'll do it differently than if you don't. This is totally subjective. It's totally helping the patient's illusion, all right? If I pull up on that frenum, I hemostat clamp it and I get all at once, it's like you take a tight rubber band, you pull it, and then you release it. The patient's gonna feel the restriction. And you're like, whoa, something just happened, all right? When you pull up and you cut. That's one of the cases that I like to use the scissors, because they can really experience it. It's not gonna affect the ultimate long-term outcome, but who has these patients there who want to feel the release? Do you guys know what I'm talking about? You got that they come in, they want to feel that they got a release, okay? Pull up, and then they'll film it. And sometimes just giving them that, like facilitating it, letting them say, yes, I'm being released, that acceptance, it actually works. Their whole body calms down, they start to loosen up, your dissection's easier, they're not fighting you as much. When they're incredulous, when they're like, do you really know what you're doing? If they're doubtful, if they're not experiencing it, then they're going to be tight, they're going to hold themselves tight. When they hold themselves tight, they're going to heal tight. Does that make sense? That's the role of craniosacral therapy. That's the role of using products like CBD and things like that. Let me show you the before and after here.
Good. Lift up your tongue. Drop your tongue down. Open big. And lift up your tongue. That's good. Lift up your hold. Very good. Okay. Now, watch your tongue down. And lift up your tongue. Good. Watch your tongue down and lift up your tongue. Watch your tongue down. Lift up your tongue.
You guys are seeing the restriction and circulation, yes? All right, so I go ahead and I release it. Here she is afterwards. She's narrow. Okay? And then here's what she says. Hi, tell us what your experience was here.
I can definitely breathe more. It used to be like this, where it would feel comfortable. Now I can actually breathe deeply. And I do a lot of deep breathing meditation, so it doesn't feel constricted anymore. Yeah.
Amazing, amazing, so good. Congratulations.
Thank you so much.
All right, so we talked about tongue tie and the fact that tongue tie, can it cause low tongue posture? What do you guys think? Is tongue tie the only cause of low tongue posture? No, right? What else causes it? Intraoral fascia restrictions, extraoral fascia restrictions, mouth breathing, tongue space. All of these are published in that article, Zaghi 2021. So we have a patient like this.
Very good. Lift up your tongue, touch your front and teeth. Good. Show me your suction hold. Good. And then put your tongue to the back of your throat like you used it.
Does he have a posterior tongue tie? No. So why can't he get up the back of the tongue? Is it a tongue tie problem? Is it a tongue tone problem? This is a tongue space problem, right? All right. All right, very, very good. So tongue tie, tongue tone, tongue space. We showed anagnosis case showing that if you don't have enough tongue space there and you go in, you're not going to get a more optimal result. Here's her case again.
Open up your mouth for me. Good. Lift up your tongue. Okay. Press down your tongue. Good. Suction hold. Breathe function. Open up your mouth a little big. Lift up your tongue. So still, just with the tip, just the tips, and still forward mouth elevation. So we're going to talk to her about revising this in the future.
All right. So again, someone mentioned this is Anna's case, okay? You're measuring not only the intermolar width, but you're also looking at anterior posterior. The anterior posterior is affected because it's highly subject to head and neck position, right? If you lift up the head 5 degrees, how much of a change will you experience in the airway? Any guesses?
20%.
Right. So 25% change, okay, for just a mere 5-degree elevation in the head. All right. So that's what we published here. This is going to be published this year, and the manuscript on my desk. If you go up 5 degrees or down 5 degrees, it affects the results by 25%. If you go up 10 degrees or down 10 degrees, the results are different by 86%. What's that? Next one down here, I think. So that's 86% difference. So in terms of how we do our CBCTs, this is the protocol. Natural head position, horizontal visual access. Why horizontal? If you're looking up, it's going to affect it. If you're looking down, it's going to make it less. Close your mouth, breathe through the nose, place the teeth together. If the teeth are apart, that's one of the dimensions, right? So you have transverse, anterior, posterior, and your vertical dimension too. If your mouth is open, it's going to affect the measurement. It's going to increase it. Swallow once, then rest your tongue where it naturally goes. The bite registration is going to push back on the tongue. It's not going to work out. Chin rest. What do you think chin rest is going to do? Chin rest does one of two things based on our research, okay? So here, group A is head tilted down. So if you tilt your head down, the airway gets smaller. Makes sense, right? Group E is head tilted up. Head tilted up opens the airway in those measurements. You have standing versus sitting, okay? When you're sitting, the airway flattens out. When you're standing, the airway opens up. All right, keep that in mind. Swallow variation, that was the control group. If you swallow once versus swallow twice, you get no difference almost. That was our control group. And then the other one is using a chin rest. Using a chin rest has a tendency to do one of two things. Either it'll push down, you come in and you push it down. What will that do to the airway? Smaller. Or you reach into the chin rest. What will that do? Opens it up. So the anterior posterior is a little bit difficult. It's super subjective and requires an assessment of what we call the N-Masion Basion C3 angle to see like where we're at. And the usual measurement for this is about 115. If you're very obtuse or very acute, that can certainly affect the interpretation of the here it is. Of the scan. Okay, so when you're looking at these things, it's really easy. You see the palate there, all right? Just make sure the palate's kind of horizontal, all right? If the palate's pointed up or the palate's pointed down, that's a clue. If you don't get it there, then you can measure out the NBC3 angle. This is what I'm kind of indicating to you guys as my ranges for what's acceptable and what's not acceptable for intermolar width. Other doctors, so this is based on measuring the intermolar width for the CE junction, cemento-enamel junction of the mesiolingual cusp of the first molars. So this is the, I have to look it up, right? So this is the cementum, this is the enamel, right? So it's the cemento-enamel junction. Is this helpful for anyone or just me? Maybe just me, but hey, me and Chad. All right, we got, everyone else knows CE junction, right? Yeah, fantastic, okay. Me and Dr. Malik, all right? That's not the only way to measure it. Another way of measuring it is the intermaxillary distance. This is how some of the ENT groups are measuring it. They don't know about CE junction, the ENT doctors, all right? So they're doing intermaxillary. So this is Dr. Eric Tuller out of Brazil, and the way that he measures it is how your upper lip, the bone is. And these have different ranges. Normal ideal is 34, mild to moderate is 30, and more is severe. If I'm measuring it one way and he's measuring it another way, what's that an example of? Measurement bias, right? They're not comparable, all right? We're talking about apples and oranges. Yet another way of assessing these is the bone width, and the Penn group with Mariana Evans and others, the buccal maxillary width is about 60, and the mandibular is about 55. And the top should have about 5 millimeters more bone than the bottom. Questions, comments? Good. Do you guys, so I have more cases. Do you guys want to take a break? Do you guys want to see more cases? Why don't we do this? I'll play a case, okay? This will be a laser case. I'm going to show the different kind of settings that we use here. And let's just see. Okay, this one I showed. So I'm going to show you guys the next case. And this will be using the different light scalpel settings. If you want to take a break, this is the time to do it. Otherwise, we'll see how we approach this case.
Sorry about that. So, hello?
Section hold. Section hold, big, big, big.
All right, we're going to see two cases. One first one is scissors case. I'll take it and see the laser case, okay? So this is the new way that I do the scissors. This is the new way that I do the scissors. Much less bleeding in the other case, right? Questions or comments about the scissors case? You want to see the laser case? Let's go forward one video. You want to play the video?
Drop your tongue down. Open up all the way. Good. Here we are. Now lift up the tongue. Lift up just the tip. Okay, so you have a lot of floor mouth compensation. Well controlled with this maneuver. Let's see if you have any jaw compensation. We'll use this. Close your mouth. Lift up your tongue. Just reaching. Do a suction hold. All right. So not too much jaw compensation in this case. Primarily floor of mouth compensation. And that is well controlled with this floor of mouth hold maneuver. Lift up. Good. Lift up your tongue. Good. So you can see here that if you take the measurements, open up all the way.
This is about a 46 CMO with the tip of the tongue comes from the papilla. This measurement is a 27, so divide 27 by the CMO for me, Amanda. And do the suction hold. Good. So he's able to do it, but he's doing it at the expense of his floor mouth. He's compensating. 29? 40. So his range of motion, open up your mouth, lift up your tongue, is 58%. 58% is like grade 2. But what we see is that it's actually compensating from a grade 3 or 4. Lift up the tip. Yeah, probably like a 3 or a 4. Compensating to a grade 2. Lift up. All right, so we're going to release him, and now we're going to see how the grading works out with this compensation hold. Very, very good. All right. Open up your mouth for me. Lift up your tongue. Small injection right here, okay? Here it is. You're going to feel this a little bit. You're feeling it a lot more than a little bit. Close your mouth. Sorry about that. Open up your mouth for me. Lift up the tongue. The closer you get to the tip, the more sensitive it can be. Close. Good. And lift up your tongue. Very good. Here we go. Good. How we got it? Do the suction hold. Huh? Good. And close. Open up your mouth for me. Lift up your tongue. So you can see it's pretty vascular here. As you withdraw the needle, you can see it bleeding a little bit. Close the blood vessel right there. So we're going to use the laser to strike this case. Close.
So you guys see I put the needle through the blood. You know the blood vessel there, right?
You don't feel this, right?
No.
Good. Okay. Let's use that suction hold.
So I hemostat across it, and hemostat's going to cleanse that little capillary a little less.
Now we're going to use the laser. We're going to close the setting. You want to switch the setting for us? All right. All right. Section, hold for me. A little leading, that's okay.
You guys see the blood vessel there? Trying to stay out of it. Went through it there. I go up and down. You guys notice that? And the goal is to get the fascia to wrap up the blood vessel, not to perforate the blood vessel. Staying pretty low. What do we have there? Genioglossus.
And suction hold. Good. Right up.
So the genioglossus setting has more coagulation to it. Any questions or comments if it's coming up? Feel free. Was this helpful for you guys? Thumbs up?
you just keep going on that and after the genioglossus, you know, if there was an outcome stays flat?
Yes. Yes, that's one outcome. The other is I don't want the genioglossus muscle pouching out, protruding out when I'm holding it this way. I want it to look flat with the rest of the tongue. If the genioglossus muscle sticks out, then you'll get scar tissue developed in that area.
Much better. Let's do a full mouthful test. Okay, Terrific, terrific. So good. Good stuff. Very, very good.
Why couldn't you do that?
Okay. There you go. Terrific. Touching up a little bit more. Very, 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 very good. Terrific. And we know we reached our endpoint. The genioglossus muscle is pretty close to your ears. Take your time, count for me. Very good. You lift it up here. Just make sure it's a little bit still anterior. So give me the laser a little more. See how the genioglossus muscle is still a little bit anterior here? DG, huh? Is it right on there?
This is what I'm explaining that, right? This needs a little touch more.
It still looks a little tight. Okay, and lift your tongue and close. Good. And close it. Very good. Very, very, very good. Excellent. Open up your mouth. Touch and hold. Very good. Looks terrific. We're going to start to close now, okay?
Yes.
Touch and hold.
There are kind of different. Some of them are, they appear more wide, side to side. Do you have to think about creating more tension when you're suturing that back up because you're breathing a wider?
Terrific question. So the wider you go, the more and more tension there is on the wound in the front, right? The way that you want to start to close those is start from the top. So just bring the top in, middle in, and you'll find that the tension will subside a little bit. If it's high tension on the bottom, sometimes I support that with periapical glue or glue stitch so that it can really hold. But absolutely, you want to weigh making the wound larger versus going deeper. Does that answer your question?
There's a lot of tension on this. I'm probably going to figure out how to close some of it. There's a lot of that was really nice to know. It's going to turn out really good.
This is for oral
Open. Close. Let's stick out your tongue. Good. So suture.
Notice I'm holding the tongue with the gauze so it doesn't slip out.
You gonna watch? So this mucosa is kind of thin.
Okay, see how the mucosa is thin right there? That suture is not going to hold. It's going to tear if he tries to do myofunctional therapy with it, right? So what do you think I'll do? What are my options here? I can either mattress it, all right? But let's say, I'm not quite there to put a mattress. Any other solutions? A little periapical glue can also help kind of support and retain that area.
Swallow. Open your mouth again. Stick your tongue out of your mouth. Very good. Just take a little feel. There's a little temptation in the laser. Not faster. There's a little bit tighter there on my finger here. Close and swallow. Stick your tongue out.
Yes, please. all patients will have tongue space. Almost all adult patients will have some degree of tongue space. So I'm glad you guys brought that up, and I'm going to show you a couple case studies to kind of tell you after this, like, when do I do it, when do I not do it? You should always have that discussion. I did have that discussion with this patient. As long as they understand they have the tongue space issue, and they're not like super narrow and super obstructed, it's okay to go ahead. What I'm trying to convey is that, like, you can't like blind your eyes, or I saw some lecture slides of people with their heads underneath the ground. You can't not address it. Does that make sense? So you're concerned about it, you have that discussion, you decide what you're going to do first, second, and then you proceed. I'm not saying don't treat tongue ties, I'm just saying know how to sequence it, and that's okay that we did it. It's okay that he has a tongue space issue. This is not like an older patient with severe sleep apnea, very narrow posterior space. Is that helpful? He has scalping for sure. It'll be unusual to find a tongue tie patient who's not like 34, 36 millimeters. Do you guys agree?
Yeah.
Yeah, so it's going to be unusual. The tongue tie is affecting their arch, of course. Of course tongue space is going to be there. But if you released it once, don't go back and release it again until you address the tongue space issue. Like in Anna's case, I released it, you know, it's still tethered. I'm not offering her revision until she opens it up. Is that helpful? Okay, are you guys good with this case? Okay. Let me see the dog here. You can go forward. Go forward again. Okay. 10 seconds, forward. Forward again. Okay. At the end of the case, let's see if we can listen to the case. Go forward. Forward again. Okay, so this is the periapical. This is the gluteus line, okay? First, make sure it's dry, totally dry, okay? A very little bit, very, very little bit, and you don't want to run it continuously.
You don't want to do it continuous.
If you run it continuously, the whole thing comes off. So a little bit, leave a little space, a little bit, leave a little space. If you leave it continuously, the whole thing comes off all together at once, and it tightens the whole thing up. So like you're buttoning it, rather than zippering it. So you apply it, you have a wet gauze to dry up the excess, and then a dry gauze to kind of activate it and dry it up a little bit. Questions, comments about that? Is that helpful to see? Anyone going to implement that? Try it out? Let us know what you think.
Good. Drop right there. Wet. This is the excess, you want too much material. Very good. You all set?
Okay, that's the case.
I'm not paying attention here because
Oh, you play it. Play it.
fingers.
Maybe you're charging for it.
Yeah, I mean, I can do something close,
Go back.
but I feel like even this movement is easier.
Amazing. Amazing.
Yeah.
What? You know?
So I'm using these bite blocks as my next stage of research. You guys are the first ones who are hearing this. There's 3 levels to the bite blocks. Right. You can switch back to me. Okay. So this is something that I'm investigating as a way to control jaw compensation, right? So we talked about floor of mouth compensation, floor of mouth hole, but there's some patients who use their jaw to lift up their tongue. You guys know what I'm talking about? Okay. So what I use is I use a bite block. When you have the bite block in there, you can't use your jaw. The way that I'm numbering this for our research, if you guys want to try it, just so we're on the same page, the TIP, the touch the papilla, you should be able to do it to a level 3. So you put the bite block in on the biggest level, that's level 3, and you should be able to lift up. Okay? If they have a lot of jaw compensation, with their mouth opening, this might be helpful.
LPS, the goal is level 2. So it's on like the medium side. Level 1 is the really small side, and if they can't do it, it's level 0. We're moving towards this because the TRMR is like hard to do. You're doing myofunctional therapy via Zoom, you can't really assess. So if you just have this, a bite walk, and you lift, you can see a lot. What are your guys' thoughts on this? Do you have any advice for me as I do research on using a bite block for floor of mouth compensation? Is it worthwhile to investigate? Worthwhile? You guys are interested to come back next year and see what we did with this? Okay, great. A couple of things that I want to direct you to is the way that I'm holding the tongue. Sometimes you have the patient just lift up the tongue themselves. Other times you can push back. One of my favorites is the butterfly approach. Okay? In this way, you're actually pushing on the lingual veins. If you have a lot of bleeding, you can just kind of pinch that. It subsides. You have a much better approach. Another one that I like is the push-back approach, where you're pushing back along the floor of the mouth and running your finger to feel for sources of tension. Sometimes you can have an assistant push back. So if you ever have proctoring with me, those are the different ways that we do it. In terms of the procedure, we start low. So we put topical anesthetic, local injection. I'm using more and more, I'm using Citinest without epi because the pH is lower and doesn't hurt as much. Other times I use Lido with epi or Marcaine with epi. It's important to know how much you can give. I've provided you guys with a table of how much it's okay to give. So in this circumstance, these are the AAPD guidelines, as well as how much of the anesthetic range you can give, whether it's Lido with epi, bupivacaine, or prilocaine. Keeping in mind that a typical carpule has about 34 milligrams, right? And the total maximum you get lidocaine is about 300. So you can give up to 10 carpules. I wouldn't recommend that at all. That's like way too much. You barely need like 1 or 2 carpules. But it's good to know like what your ranges are, okay? For children, they have it based on ages here. And for children, you just want to be very, very, very judicious. In general, you can get away, this will tell you how many carpules, right? Like 1.2, 2.4, 4.0, like how many cartridges or carpules can you use? Is this helpful to you? Okay, so for under 5 years old, you're talking 1 to 1.5 carpules. Okay, maybe 2 carpules. And this is already pretty conservative, so you could go like twice as much, but you don't want to. For 11 years old, you could do 5 carpules. Questions, comments, disagreement? Tell me if I'm wrong, because I don't want to teach the wrong thing. Yes?
And some other people might do this. I'll give my first injection to Citinest.
Yes, Citinest first.
Then I'll switch to lidocaine.
Totally agree, and I just don't have that. Yeah, totally agree. But how many carpules can you use? Right?
Very rarely use more than 1.
Very rarely more than 1. But do you guys agree that the maximums are around like 2 to 5?
Yeah.
Pedodontist, am I correct? Thumbs up? Okay. Because the question comes up, right? Like how much can you give? You should know, don't you think? The way that I inject is I start low. Like Dr. Stewart said, I've learned to first inject with Citinest, which is a higher pH as compared to lidocaine with epi, which has a lower pH, right? So here are the pHs. Citinest pH is 6 to 7, it won't burn. Lido with epi, Marcaine with epi. Anything with epi is buffered in an acidic solution so that it burns. You could buffer it with bicarb, that works well, but it can be complicated. What do you guys like to use? Anyone like to use, anyone buffering their lidocaine? Buffering, like to buffer? Anyone using Citinest? Or anyone using Lido with epi straight away? Okay, there's a variety of different approaches. So you start low, you work your way up. Then you go step-by-step approach. I use the hemostats, do the frenectomy, and it's really like a step-by-step approach where you're kind of feeling for things. The sutures, you definitely want to be above the sublingual caruncles. You don't want to get into the sublingual caruncles. A big component of my procedure is suturing. Strongly advocate for suture. The smaller the wound, the smaller the scar. Do you guys agree with this? Smaller wound, smaller scar? Anyone? Yep. Okay. So we'd love it if you guys could learn how to suture.
The different suturing materials that we work with are fluorochromic and PTFE. Our colleague here suggested silk. Here's an example of me using PTFE suture. I like the PTFE when there's prior inflammation. Here's what it looks like. Here's what it looks like 1 week out. The other option for closing wounds is periacral. You can use the periacral one of two ways. You can use it as secondary intention, leave the wound open to squirt it in, all right? And another way is to get the wound edges together and then use it to seal it, so you're still getting first intention healing. Using the periacral, use very little. You guys have the slides here. But again, you don't want to squirt it in there, all right? You want to get the wound edges together and then seal it. Does that make sense? Is that helpful to you guys? Right? Which do you think will heal better? This one or this one? The secondary intention or the primary intention? Primary, very good, all right? If you're gonna put it on sutures, don't run it all the way across, up and down. It'll just contract the whole thing. Put a little bit, give a little space. Put a little bit, give a little space. We're doing research on our wound healing outcomes. Our post-op instructions have changed. What's the difference if you use periacral? What's one thing that you can't have the patient use if you apply periacral to the post-op instructions? Do you guys know? How do the post-op instructions differ from periacral? Periacral is dissolved with vitamin E oil or mineral oil or things like that. If you use periacral, they cannot use vitamin E, they'll just wipe it off. If the periacral is too thick, you need to brush it off, you put a little vitamin E oil. Does that make sense? Very good. For some patients who have anxiety, I like to do these primarily away from the local anesthesia with no nitrous or sed. That's my preference. Some people like to use anesthetics. We do recommend for patients who have a lot of anxiety, they can try dial cure CBD, a lot of anxiolytic benefits. This is the dosing for it. The good thing about dial cure is that you're getting like exact dosages when you're taking it. So in general, you might start with like 10 milligrams and maybe work your way up to like 30, 40, or 50 milligrams. Question comes up about partial genioglossectomy, okay? So it's not, that's when the genioglossus muscle is being protruded inwards. We learned from Nikki Mills's article that in some cases it's just a mucosal frenulum, other times it's mucosa and fascia, other times the genioglossus muscle gets pulled up into the frenulum, and it's in those cases that we have to go through and really dissect it. Are you guys seeing that there? How it's sticking out? I've showed this video a few times, I won't show it here. Here's another example. Do you guys see how the muscle is kind of sticking out here? So we want to push this back. Again, indications for genioglossus are if there's fascia that's adhering to the genioglossus. That's this example. Yes? If the genioglossus muscle is restricting tongue mobility, and if the genioglossus muscle protrudes through the ventral surface of the tongue, like this one. Other comments? Any questions? Yes, please.
You use non-resorbable sutures. When do you remove them?
Even the non-resorbable sutures will come off on their own. You can consider seeing them 1 to 2 weeks post-op. Yes?
A question about the CBD. Is that something that you're giving at the beginning, like at your office?
Yeah, this would be done at the consultation. If the patient's like super anxious, asking to be put under, like not okay, then we recommend craniosacral therapy. You want to comment?
We do have an office in Oregon, the colleague that introduced us to this product because it's actually citrus terpenes.
It's synthesized from citrus terpenes instead of actual cannabis products, so it makes it more applicable to people that might have a hesitance to cannabis products or
So
that.
that office is actually trying the protocol, and they're going to get us some data of administering it a week before the procedure, and then continue to do it a week after the procedure. So we'll have more updates for you there. But yeah.
Very good. Other questions, comments? All right, let's take a look at some anatomy. Are you guys good with the pace of this lecture so far? Let's get some energy. Woo! Yeah. All right. So colleague came up to me like, I cut the lingual nerve. What do I do? How do I avoid that? I think if you're going to be an expert frenuloplasty provider, I think it's really important to have the anatomy down. So let's go over it. Okay. So the nerve that's pointed here is the lingual nerve. It's wrapping around the submandibular gland duct.
as well as the lingual nerve, lingual artery. All right, we're going to see 3 examples of the nerve. Let's study it carefully.
I'm going to show the anatomy of this case. Every time after the front teeth. All right, so we see the genioglossus. Show me cave. So this is the genioglossus muscle. Okay. Adjacent to it right here, there's a white structure there. This lingual nerve.
You guys seen it?
And just behind it and lateral to it, we have lingual vein. And on the other side, here's the lingual vein. And we're not really seeing the lingual nerve here, which is quite it. But I thought it would be a good demonstration.
Notice when the suction pulled, it gets pulled away.
Thank you.
Helpful so far? You want to see another example?
Make sure the anatomy of this
Yeah, it's not this one. Okay. So, lingual nerve, yeah? Lingual nerve. More anatomy here.
Lift up your tongue. Suction hold. Beautiful. Here's the anatomy. That white structure in there, deep. You guys see that? That white structure, that's nerve. This purple structure is vein. In the middle, you have genioglossus. There, that white structure, deep, is nerve and vein. Here you have floor of mouth. This is the sublingual duct. Carancles are right here. Let's just stick your tongue out. Lift it up. Okay. This right here is ducts that feed the anterior lingual wing. You have lingual vein. Good. Suction hold one more time. That's a great demonstration here. Right there, that white. So you see that white in there, huh? The nerve in there. Close. Lift up.
What do we have here? Nerve, right? Is this helpful for you guys to see? There it is, right? It's pretty close, right, to your cerebral field. Good, all right. When they have floor of mouth elevation like this, it can make the surgery more difficult because you can't really see where you're going. One problem that can arise when they have a lot of floor of mouth elevation is they're actually lifting up the sublingual gland. So when they're lifting up and they're pushing up the sublingual gland, and you do the release, look at this floor of mouth elevation, right? What's under here? What are they pushing up at me? Sublingual gland. So when you open it up, what are you looking at here? Okay, so if you keep going into here, what's going to happen? You get a ranula or a sialocele or other problems, yeah? So it's important to be aware of the anatomy. Like, there's no more tongue tie there. It's not fascia. It's not genioglossus. Just leave it alone, and you cover it up. There are other glands other than the lingual glands, the sublingual glands. You have the anterior lingual glands that run under the surface of the tongue. These are the glands that blood and run, and they stick out through these little ducts on the side. As you're closing your surgery, you don't want to get the ducts. If you trap the ducts, you get a little bit of sialocele that develops in that area. So, using the lingual glands. So let's do a little pop quiz here. Number 1. What do we have number 1? What are those? What's the green there? Anterior lingual gland. Okay. Number 2. What's number 2? Say it loud and proud. Lingual nerve. Great. Number 3. Genioglossus. Number 4. Vein. Number 5. Artery. And you have the duct there. Someone posted this on Facebook. I'm doing the surgery. What's this structure here? In the midline, pretty deep. Okay? If you ever forget, just go to Google, type in tongue anatomy. Alright? You get a picture like this. Alright? Do you want to find out what that is? Not at all, right? Way too deep. I mean, there's no fascia in there that just needs to be released. Do you see the little purple that's coming out of here? Okay? That's really dangerous, right? Way too deep. So one thing that you've noticed in our surgeries is we're way less deep now. Okay? So what you have here is deep lingual artery, deep lingual vein. Let's trace it out. Deep lingual vein comes off of what? It comes off of the internal jugular vein. an external carotid artery. It's serious stuff. If you do get into it, okay? I'm not encouraging it, okay? But if you do, what are you going to do? Okay? So here's very, very important. You hold pressure. You hold pressure, okay? It will stop, okay? Imagine you have a tourniquet on your arm, 120 or 80 millimeters, it's going to stop. You hold pressure right where it is. After that, you have to consider a few things. Is it a small capillary? Is it like small, super teeny? Maybe use a laser, okay? Is it a little bit bigger? If it's a little bit bigger, you're going to tie it off. You don't tie it off by putting your suture through the vessel. That's not how you do it. You tie it off by bringing it around the adjacent tissue, or adjacent mucosa and fascia, and you're using it to put pressure on the vein. Does that make sense? What would happen if you put your needle through the vein and tied it off? What would happen? Go there. You tear it worse. Right? You tear it worse. God forbid, God forbid, God forbid. I hope this never happens to anyone. Let's say you do that. Okay? You've torn the deep lingual articular vein. Worst case scenario, right? You take it to the OR, like I'm there, it's uncontrollable. Worst case scenario, how's this treated? Worst case scenario, it never happens. Okay? Here's what you do. It's called interventional radiology. Okay? It's unfortunate, but we do it in head and neck surgery. Let's say I'm doing tonsillectomy or get a major bleed in the nose or something like that. These things happen. I've had it happen multiple times in residency. Okay? We're in the nose, juvenile nasopharyngeal angiofibroma, and it starts hemorrhaging, like liters, like hemorrhaging. Okay? What you have to do is you hold pressure, you have your hand in the patient's mouth, or whatever it is, and you go to the IR suite, or you get transferred to the hospital while you have your hand on it. They're going to put a catheter through the femoral artery, femoral vein, go all the way up, and they coil it off on the inside. This is worst case scenario, but I think it's helpful for you guys to kind of know what's your plan Z, right? Is that helpful for you guys? Is that surprising? Or do you guys already know about that? Or that's what we do in head and neck surgery, right? You're up in the throat, you're doing your best, you're tying it off. Worst case scenario is you have to embolize that vein or artery or whatever it is. They coil it off as if you're having a hemorrhagic stroke, and there's bleeding going on in the brain. It's the same kind of process. Helpful? Yes. Questions, comments? Don't go there. Let me sleep at night. Don't Facebook message me. What is the structure, Doc? Yeah? All right, know your anatomy, and be able to see your anatomy. You can study the anatomy, have good visualization, have good light, have good lighting, all right? If I come to talk to you, make sure that you can see, make sure that I can see. Loops, you don't want to be too focused because you're going to miss the bigger picture. Don't use the scissors you use to open up envelopes on these cases, okay? We figured it out. We have our GenMed. It's really high quality. Strongly encourage you to get a set. If you don't have it, even if you're using the laser, I still strongly believe that you should have at least a few of these surgical sets. The tools work a lot better, okay? They're fine forceps, they cut right, they suture with the right amount of force. So really encourage you guys to pick one of these up. I encourage you guys to practice suturing, okay? Not at your desk. When you're suturing at your desk, you're doing it in a different orientation. You're suturing towards your side to side. Suture as if, take your little skin, go to the head of the chair, have your assistant there, be in the right orientation so when you're operating that day, you know how it's supposed to feel. Are you guys with me? Helpful? I feel it would be important. We're talking about our protocol, right? So I feel like it's important to talk about our bleeding protocol. Number one, always look before you cut. Always look before you cut. Okay? You can check with an injection. Just make sure. If you do get bleeding, the first thing is apply gauze and hold pressure. Not just anywhere. Hold pressure from where it's bleeding. Okay? Stay calm. Stay focused. If you're out of shape, you're not making good judgments. If your heart's racing fast, don't try to suture anything off. Don't try to do anything off. Just hold pressure until you're calm and you're good. You peel back the pressure off the gauze until you can see where it's bleeding from. You're sure that's the source. Then you treat accordingly. Let's see this case. All right.
The instruments are no good. You see how thick they are? That's not good. Okay. That's the first one. Whenever you throw a suture, make sure you look. Okay, go ahead. Yeah. All right, get ready. Get your popcorn out. What did she get? Lingual vein. Okay. That's the butterfly. Nice thought, but that's not where it's bleeding from. Okay? Good job suctioning. What do we have here? Okay. So you just gotta, it's not coming from the tip. Actually holding the tip's making it worse. Okay? So stay calm, hold pressure from where it's bleeding. The way that they're doing it now is just making it worse with the pressure on the top there. You want to be under it, not on top of it. Does that make sense? All right, so look before you cut. You gotta see it. You're not, anyone gonna take a laser in there and just go zzz? No, right? Absolutely not, yeah. Hold pressure and it'll, worst comes to worst, the body has platelets, von Willebrand's factors, hemostasis cascade. Even if you're taking like medicines and you have a variety of coagulopathies, your body will still clot it up. It just takes longer, okay? So normally it should clot up like 1 to 2 minutes. If you have a coagulopathy, it takes 5 or 10 minutes. It's not gonna not seal up, okay? So just kind of know that if you hold pressure long enough in the right place, the body will heal it. All right? Yes?
You have to tell people how it ended, because she did good.
She did good in that, yeah, she got it. She held pressure, and so you pierce the vein, right? You pierce the vein. What are you going to do? Are you going to leave the thread in there? You pierce the vein. Is leaving the thread in there going to help you or hurt you? Hurt you. It's going to keep it open. So you want to take it out. Now, are you going to try to tie it down? No, it's going to tear it. So you realize that she went into it with a little needle like that, right? It's not a big deal. It's a small needle. You hold pressure. The body, whenever you have the raw edges, von Willebrand's factor goes and grabs there. It makes a platelet plug. The body brings fibrin and other hemostatic agents, okay? You remember learning about this? Like factor V1, V5, V7, all right? It's gonna plug it up. That's okay. You're all set. Take it easy. Don't go looking for more genioglossus muscle, okay? You're good. You're all set. You're done. All right? If the bleeding is coming from a muscle, you try the hemostasis, it didn't work. You can do a little bit of periacral, but be careful, okay? Best thing is to hold pressure. You can use a little periacral, it'll seal it. But when the periacral comes off, then you know the issue there, okay? Yes?
Can you talk about, like, you had a case where they went through the lingual nerve?
Yeah, there's a doctor here who mentioned that to me. They put it online, he's very humble, he's his assistant. They said that it was like right below and the anterior 2/3 of the tongue is numb. It's unfortunate. Yeah, I don't have, it's better look at that.
Like microsurgery on it?
Maybe, I have to see the patient. It's tough. It's tough to get molar injuries. Questions, comments?
Okay? Yeah, so you really don't want to get it low. The high up branches don't matter. Those will come back. The one that's right there near the artery and the vein, that's really bad. You really don't want to get that one. Okay? Helpful for you guys? You guys want to see more complications? I'm trying. Here's a little girl whose tongue was numb, and she bit her tongue. Okay? So that's what happened there. Here's another case who was doing the stretches, and by doing the stretches, developed major bleeding. Okay? We had to do a teabag in that area, hold it, off and on. This patient presents to your clinic. What are you going to do? Laser it? Suture it? Periaqual blue? What do you guys think? It's a stable hematoma. It's a stable hematoma. What are you going to do? Make it unstable? No. You leave it. Okay? Can you guys see this is stable? Why is it stable? It's not bleeding. It's clotted up. What you're looking at there is all those factors and fibrin and all that good stuff, right? It's granulating, it's involuting, and now you're good. You guys appreciate that? Good. Do you guys want to see another complication? Yes. You want to see an unstable hematoma? All right. Here, unfortunately, they did a good job on the surgery, okay? You see in the middle there, they put a suture to the lingual vein. You see it? It's right, let me see if I can find it here. It's right here. You see this? So this is under high tension, and the tissue is really close to the lingual vein. As the swelling happens, you're going to tear that, right? And then you're going to tear a little lingual vein. Here's what happens. Okay? This is an unstable hematoma. Okay? What are you going to do? IR? Who said, what did you say? Send it to me. Fly the dog, you helicopter. Okay? So the dog calls me. Okay? This is like a second option. All right? We don't love it, but I'll take the calls. I'm not encouraging the calls. But someone's in danger, I got help, right? So we said, okay, stay calm. So it's going to be okay. What you have to do is you have to go through the fire, right? So it's like the house is burning, you just got to go through it. You got to make it a little bit worse before it gets better. So what you have to do is you have to dislodge the clot. So you go, you wash it out, you spit it out, suction it out, and then hold pressure. Okay? The problem, so this is what it looks like after the washout. All right? And a little pressure. So the problem is that the blood vessel's bleeding into an abyss. Okay? It's not able to make that seal. So you get all that stuff out, and then you give it a new surface in terms of the cotton, and then you wait, and you let the platelet kind of hold there. If you put the gauze over the unstable hematoma, you're never going to get the sealing to happen. Does that make sense? Mm-hmm. Questions, comments? Was that a helpful case to share? Questions? Good? All right. Eiffel Tower compensation, I don't get directly. I get indirectly. Okay, I'm sorry. I don't cut through the attached gingiva, right? You go into the freedom, you release the fascia, and you push it down. The Eiffel Tower is not the problem. It's a sign of the problem, right? Treat the problem, not the sign of the problem. Here's a case in which they went after, this is a revision case I did. They released the Eiffel Tower and the tongue. They're doing tongue stretches. How does it heal? The sublingual caringle is attached high. You see that? So I repaired this case similar to the Kaiser case I showed you. The way that I did it is I turned this grade 4. Can you see my mouse here? Can you see my mouse screen? Yeah. Maybe not.
Yeah.
Okay. So I made a little cut here and a little cut here, and then I sutured it. Okay? Then I made a little bit more of a cut here, and a little bit more of a cut here, and then I sutured it. I made a little bit more and a little bit more, and then here, you see I brought it together like that. So you turn the grade 4 into a grade 3. Take a breath, drink some water, come back, you go to grade 3 to grade 2D, to 2,
to 1. You take it step by step. Don't try to jump all the way. Create a big hole, big mess. When you're dealing with these cases, remember the ABCs, always be closing, okay? So you always have to plan your exit strategy. And so here's how the case healed. Okay? If you're not up for it, it's okay. You can come out, bring your patient with me to my clinic, we'll do it together, I'll show you how I do it, or send it and ask for a video of how I did it. I'll be happy to share it with you, okay? In a case like this, like referral to Dr. Zaghi, please record a video and send it to me. I'm more than happy to do that, show you what I did so you guys can learn. All right, so here she is before, 3 days post-op, and 3 weeks post-op. So it's good, better, best. Never let it rest until your good is better and your better is best. Featured in the same with Dr. Stewart. I mean, how many of my lectures have you heard? We've done affiliateships, times he's visited. Here he is in the front row, still asking questions, and I appreciate your collegiality and your mentorship. More complications? Yes, never let it rest? All right, so let's see what happened here, okay? So in this case, this is an important case, all right? They did a nice job with the surgery, but had a really bad complication post-op. What happened? What happened here? Why did this case go wrong? Okay? This patient had a pretty benign surgery, right? But had a little bit of swelling afterwards. Is it normal to have swelling after surgery? Well, what if you don't have enough space in the mouth for the tongue, and the tongue swells up? Can you guys see here how she's squeezing the tongue in there? So now, there's blood vessels, when there's so much pressure in there, lingual artery, lingual vein can't drain. You get back up, and you get this picture here. In this case, you just have to do supportive management. The body's going to heal itself. It's all going to work out. But the important thing is the tip is still numb because you're putting pressure on the nerve, right? Tongue tied, tongue tone, tongue space, yeah? So for the next little bit of time that we have, I'm gonna go through the philosophy of tongue space and then get your advice too, because I want to see what you guys think. And is Megan here or not, Sarah? Just you? Is Megan Benno here? Okay, so we're gonna show your case, okay? So first of all, what we're working on establishing is tongue overflow. You do the lingual palatal suction and you look for the overflow. This is going to work better than Malampati, okay, or Friedman. Malampati, you're sticking out your tongue. Do you guys agree that that's not that useful? If you're going to do Malampati, at least do Friedman. The difference is you're not sticking out the tongue. Any questions, comments? Does anyone disagree? Sleep surgeons use the Friedman classification, all right? Only anesthesiologists use Malampati, and I think the dental community uses Malampati as well. If you're going to do it, the way that I do in my clinic is I do it the Friedman way. Even then, the Friedman is not that reliable, and what's more reliable is assessing whether the tongue fits in the palate. So we have them do the lingual palatal suction. If they can't do it, then they're not a candidate for surgery anyways. They have to do myofunctional therapy. And then you're assessing the overflow, transverse or anterior posterior. Certainly you want to look for scalloping. Here's a case, tongue overflow, severe, right? And then you do the CT, okay? So the CT measurements can be done lingual or buccal. I prefer the measurements to be done lingual. If you measure lingual versus buccal, you'll get to a very different place. Measurement bias, in this example, the patient had expansion. The buccal measurements improved by 8 millimeters, the lingual measurement only by 1 millimeter. So transverse is easy, you guys all agree, right? What's hard is anterior posterior. So what do we have for anterior posterior? We have SNA and SNB. SNA is sella nasion A point. That should be about 82 degrees, SNB about 80 degrees. But it turns out that SNA and SNB are not a definitive way of assessing anterior posterior. They're like the Kotlow measurement way of assessing anterior posterior. If your SNA is deficient, then you have like a severe anterior posterior problem. Most patients will have maxillary deficiency, but their SNA and SND will still be okay. Are you guys on the same page as me? Have you guys noticed this? Another way of assessing is the porion vertical A point. This is a line drawn down from the porion, which is the external auditory canal. Take a vertical down and match it up to the A point. That should project about 97 millimeters. This has been validated in this study here. And it's one other factor that we look at. So if you ask for a beam reader's report, they will give you the PVA line distance, as well as the lingual and buccal measurements. And I'm honored to train many of the radiologists who are doing the reads. And we're grateful for them, even for coming back for continuing education. Then we have posterior airway space, right? Posterior airway space is very, very unreliable because it's very subject to head posture. In this example, the patient's tilting the chin like very slightly down. You can barely see it. But the airway measurement is 6 millimeters. Here, the head is slightly up. It's 1.3. So it's twice as much. Are you guys noticing that? So how are you going to use posterior weight as an outcome measure of, that's what makes it so challenging, because they're compensating, right? It's these grade 2, grade 3 compensating to grade 2. So what we're learning is that individuals compensate for restricted airways by the forward head posture, right? So forward head posture is a compensation for a narrow airway. And so we have to come up with alternate tools to kind of overcome this. Here you see this patient, but you can tell subjectively there's something wrong, right? Can you see how the angle's up, the palate's pointed up? So you're using these clues and you're interpreting the 1 centimeter in the context of the altered head position. And we'll be publishing this year, showing that a mere 5-degree change the airway 25%. And this is also going to affect our outcomes from palate expansion. Because what we find is that you expand the palate and you're not increasing the cross-sectional area. What you're changing is the head-neck angle. The head-neck angle goes down. And I'd like to show you a case like that, all right? So here is a beautiful dancer who we treated, all right? So here she is. She has some cranial strain issues. She was treated with myofunctional therapy, lingual cranioplasty, as well as orthodontic expansion by the Facial Beauty Institute way of doing it, the Aura method. And here's where she started: deep bite, mandibular shift, altered posture. I released her tongue tie, and she did really, really well, okay? I'll spare you, we don't have that much time, I'll spare you the testimonial. Doing so much better, my legs are able to like move around, and everything feels great. And then we take her and we put her through orthodontic expansion, right? She's like, oh my gosh, my breathing, my sleep, my posture, everything's coming together. So we would expect that if you took a CBCT, her air would be bigger, right? Isn't that what you would expect? What we're finding, though, is that it's, even though you're able to demonstrate, right, that look, like they pushed it forward like 6 to 8 millimeters, right? They like made that space. You can document it, you can measure it. What's changing is not her airway size, but rather the extent to which she has to compensate to achieve that airway. Okay? So here she is pre. Her intermolar width went from 3.1 to 3.4. So she has still a way to go, but a good 3 millimeters of expansion in that regard. If you look at her sagittal, the airway doesn't look that much different. Are you guys noticing that? What's different is the head-neck angle, that it went down by about 6 degrees. Is this making sense? So the first thing to be affected when you expand the airway isn't that the airway gets bigger. The airway stays the same size, but their head goes back. Let's have a little commentary. This is what I'm observing. Have you guys observed it? Is this helpful? What do you guys think? This is research and protocols. Ryan, any comments on this? Dr. Robinson?
It's perfect.
Okay.
Exactly what we're seeing.
It's exactly what you're seeing, right?
That's right.
All right. So if you're trying to prove to people that, hey, we're opening up airways, But what you're really doing is you're fixing their posture, which is even more important, but you're not getting the measurements. This is a research problem. And this is why we haven't been able to kind of show that when you take out 4 bicuspids, the airway size is the same. But you know what's different? Is that head-neck angle. So this year, we're going to be publishing the NBC3 angle, and we're going to be encouraging all of you guys to not look so much at the actual measurements, but at the compensation for it. Is this making sense? Just as we have the grade 1s and 2s, and we're saying for mouth hold, we're introducing measurements for head-neck angle. Helpful questions, comments? This is just in its infancy, so if you want to change the name of it, if you guys don't like NBC3 angle, you want to call it something else, now is the time. Anyone? Helpful? Yes? Okay, so this is the kind of research work that we're doing. All right, so what do we do? All right? You have to look at it more subjectively. There's no measurements. You have to ask yourself, do those puzzle pieces fit? In this case, this tongue fits in that mouth. Can you guys see that? It's going to fit. How about this case? Maybe not. How is that tongue going to rotate up and fit in there? I don't know, despite what the measurements say. And how about this case? Does that tongue fit in that mouth? There's a tongue size space discrepancy. Something's off. How about this case? Are you going to tell this patient, we'll release your tongue tie and cure your severe sleep apnea? Are you guys able to see it? Is it yes? Okay, so this is going to be a no. And we're doing the research to help us get us there. We're trying to come up with functional tongue space analyses to do. And sometimes you need to do a CT, other times you don't. But here's a patient who was referred to me. So orthodontist sees the patient, does alignment therapy, but also recognizes that enteroperitoneal bite is due to a tongue thrust and recommends myofunctional therapy. Myofunctional therapist takes a look and assesses. I think maybe one of you guys referred this to me is in the room, right? Yes, great. Thanks for being here. Thanks for your referral of these challenging cases. And do you want to speak? You want to talk about the case?
It's complicated.
What's that? It's complicated. So they're like 2 hours away. They have a very thriving practice, and I get like the difficult patients every now and then. They're humble enough to request my help in difficult cases. So what's the deal here? Why is he tongue thrusting? Is it because of his tongue tie, or is it because of his tongue space? Okay. Is it a good idea to close his open bite? No. If you do a sleep study, he may not even show sleep apnea. Just putting it out there. This guy did have sleep apnea, okay? He has severe sleep apnea. But some of these patients with tongue thrust are compensating, not with forward head posture. How are they compensating for their sleep apnea? By tongue thrust. When their tongue is forward, they're not going to have apnea. Do you guys follow? All right? They're compensating, just like these tongue-tied patients who are using their neck and their head, and they're going to have other issues secondary to it. So you don't want to close this open bite. Either let him ride the open bite, or you got to get him to what he needs, which is weight loss, CPAP, maybe MMA. I'm not sure, but I'll tell you, tongue-tied surgery is not the answer. Do you guys agree, or what are your guys' thoughts? You agree. Good. And sometimes it's difficult for the therapist, but you got a referral from an orthodontist, right? Who wants the bite closed. And you look at it and you're like, ugh. Thanks for the referral. But, so in this case, it got to my level, and I'm like, no, like leave the bite open, like weight loss, like it's all good. Does anyone think differently? I'm here to learn with you guys.
Why do you recommend it?
Of course. Yeah. But I will tell you, what kind of expander are you going to put in this mouth? You're going to put a DNA appliance? What's that going to do? What's that? You need something thin profile, right? You put a thick, bulky expander in there. This is severe sleep apnea, right? That means he's desatting. What happens with the bulky appliance in the mouth? What's going to happen to the tongue? Everything's going to mush back. Is it going to work? No. So you might consider MSC if he's narrow, which he is. You might consider jaw surgery, but the most important thing is make sure to get him on CPAP, encourage the weight loss. Tough case. Good? These cases might do better with like light wire, things that don't occupy too much tongue space. How about, go ahead.
I'm sorry, do you ever assess or comment on the masseter development, the masseter muscle when it comes to head and neck disease?
Yes, so with masseter, if it's overdeveloped, it suggests clenching and grinding, and clenching and grinding is also a compensation for airway disorders. All right, so how about this pediatric patient? Anti-open bite. Kids are different than adults, okay? In kids, just myofunctional therapy. I don't know whose case, did someone think of this case too? Is it familiar? Okay. Just myofunctional therapy. Amazing, right? In kids, you can get these results. In adults, not so much, okay? So the myofunctional therapy, this is the pre-op, okay, open mouth posture. And here he is, this is just therapy. Just therapy, how amazing. No tongue tie release. If you don't know, just start with therapy. Hey, it's working, right? This makes you feel more encouraged that you can do tongue tie first. If they're not able to do the therapy is not working out, for the life of them they can't get the suction hold, maybe you do expansion first in that case. Questions, comments about this? So I would say in this case, let's go ahead and take care of that tongue tie. Anyone feel differently? Anyone feel we should have expanded first? Okay, these are open for debate. Here's another case. Severe maxillofacial deficiency. 6 months of therapy and tongue tie release. Okay? It's amazing, yeah, kids are amazing. All of this emphasizes the role of early diagnosis and treatment. Like I talk about, catching the smoke before it's a fire. I love listening to you guys and hearing you guys talk about these same issues. It makes me so happy to see you guys carrying on this torch. So we're investing more time and resources into our Breathe Babies and Kids department. Megan, you want to say hi? This is my wife here. She's going to be joining the department and helping to work for expansion protocols, especially for kids. We're looking at a system of functional appliances, MyoGrace, Healthy Star, Velos Trainer, palate expanders, whether it's a 3-dimensional Schwartz. We're going to have Dr. Stephen Deal from the Facial Beauty Institute in, is it May? May 20th, 21st, 2-day course on RAGA approach. Not only transverse, but also forward development. The transverse everyone's got. What we're really interested in with the RAGA appliance is bringing the maxilla forward. Works really well for kids. We're going to be exploring that more in detail. And with everyone here in the community, we're also trying to figure out the root causes of these issues. Why do they develop this way to begin with? The ulcer chewing, swallowing, posture issues, small things that you never would have thought can cause big problems. This is our colleague Sandy Calleros. Is she at the conference? No, she didn't make it. She allowed me to use her picture out of her humility because she has sleep apnea. And the question is when did she get it? When did things go off track? So we take a look at her chimera generator. We see her difference in her facial profile. One side of the face is longer than the other side. One side is underdeveloped. She probably chews more on the right side. Her teeth are more in contact on that side as opposed to the left side. As the left side grows longer, you can see that her septum is deviating. Are you guys seeing that? You see how one side of the face is longer and is pushing the septum, making the septum more crooked, further blocking her breathing. We asked to see a baby picture, and it turns out that she had a cranial strain. Okay? Her sphenoid bone was altered, and because of that mild alteration in her sphenoid bone, she had a slight head tilt. Her visual access was not symmetric, so what people will do is they'll tilt slightly to make sure you have horizontal visual access. Now just try that here. Move your head all the way to the side, open and close your mouth, see where your teeth touch. Go to the other side, open and close. You see that slight turns in the head will affect where the teeth touch, where you chew, and that starts the game. Are you guys appreciating this? Mild things gets you into this cycle of oral dysfunction. And once you're there, once you have a narrow palate, it's even more difficult to chew. Your diet's going to be altered, and so on. And so we asked for her, when did things go off track? And it was probably early on in life. But for some others, like this beautiful violin player, things went off track when she started playing the violin 6 to 8 hours a day. How do you play the violin? How do you stabilize? Are we surprised that one side of her face is more developed than the other? Incredible, right? Yeah, she has a crossbite now from all this, right? And she has spinal asymmetries. But the beautiful thing about lecturing to you all is that once you see these things, you can't unsee them. Once the mind is stretched by a new idea, it never returns to its original dimension. And I hope that that is what I've done for you guys here today. If you guys are interested in learning more, we have opportunities. There is one more case I want to share with you guys. Okay, so if you guys want to learn more, go ahead and put the QR code, and then I'm going to have Megan come and share this case, or I can share it for you. Is she still here? You want to share it? Should I share it?
Whatever you want.
Why don't you talk it out while you're there? Yeah, why don't you come up? All right, so thank you guys very much. Thanks for being here. So now we're going to look at a case, right? And based on my teachings, I'm actually going to have Dr. Stewart guide it. All right, you're going to case review this case for us. Okay. Sound good? Yeah. All right.
Hi, everyone. Can everybody hear me okay? Cool, perfect. So this is a patient of ours at Vascular, Sarah Brunsby's Myofunctional Therapy Clinic, and I am her clinical director. So this is a patient who came to us. She's a traveling nurse. Let me go to the next slide. Her name's Kaylee. She must be almost 33. She came to us. She can't close her mouth naturally. She has crowding. She doesn't sleep well. She coughs when she wakes up in the morning. She's been previously told and is aware that she has larger tonsils, but as an adult and as a nurse, she is not interested in pursuing the tonsillectomy because of the recovery period. And then once we went through her comprehensive evaluation, we dove deeper into knowing more about her sleep. She's having headaches. You know, her sleep schedule's off, but sometimes she works nights. She travels through all different time zones. She wakes up with dry lips. She's got neck shoulder tension, has a hard time concentrating, and then clenching, grinding, and TMJ pain. So when we did her visual assessment, her TIP grade was 50%, her LPS was 50%, and so we talked about her being about a grade 3 who would compensate, especially with the floor of the mouth, to a grade 2. So this is Miss Kaylee. So you can kind of even see she's got a little head tilt. You know, she's a little bit back, right? Can you guys all see that? Yeah? Cool, perfect. All right, and then we looked at her clinical tongue space assessment. So when we look at these things, we're looking at the LPS. What would you guys say as far as her overflow? Can you guys tell? Mild, moderate, severe? Anybody? Mild? Mild. Mild? Perfect, awesome. All right. And then also we looked at the TIP grade. We looked to see if there's any tongue scalloping. Do you guys see any scalloping on her? I'm kind of surprised I didn't either. I don't see it. I would have guessed that there would be. And then, TIP, she's not closing very much to reach that tip. She's not, maybe minimal neck strain, not too much of, facial grimace compensation. She's not jutting her jaw out. And so She started oral facial myofunctional therapy with us back in August. She went through 6 sessions with us. We sent her and referred her to one of Dr. Zaghi's affiliates for functional frenuloplasty. She had a watchback sleep study. She was diagnosed with mild positional sleep apnea. She also had CBCT imaging, 8 millimeters of posterior airway space. Her intermolar width is 31, so we can call that narrow. Tonsils grade 3, and then she's also told she has a deviated septum, which she previously knew about as well. So let me pull up the beam readers report here. Can you guys all see that? And that basically broke down what I just put on that slide before. But we do see she's narrow. We do see she's missing some premolars, right? But when we looked clinically at her tongue space, she passed all of our tests, all of our assessments. So you can see here, even more with the beam readers, that posterior airway space, 8.39 millimeters. You can also see her tongue's up in the roof of her mouth, so good for her.
Was the scan taken prior to myofunctional?
No.
Okay.
No, so this is after working with our myofunctional therapist. Mm-hmm. Yep. And then we did her sleep study.
Let's go back. What was the posterior tongue space?
8.3.
8.3, okay.
Mm-hmm. Perfect. And then we did her sleep study. She did a watch back. Dr. Zaghi read it. And the findings from that were mild positional sleep apnea. So everything came back mild. Her RDI was fairly low as well.
So on the positional sleep apnea, was that a diagnosis that you made, Dr. Zaghi?
Yeah.
Yeah, would you explain to them what that means?
Yeah. So, great case so far. So perhaps the biggest problem or risk with doing a sleep study, the biggest risk of doing a sleep study is what? Of getting a false negative diagnosis. Very dangerous, very dangerous. There's a patient, needs help, you're trying to get them the help that they need. You do a sleep study, the sleep study comes out normal. I saw a case someone showed me, there's a kid with grade 4 tonsils. Whose case was that? Who kind of pulled me aside, right? Where are you located? Miami? In Florida. Grade 4 tonsils. Did a sleep study. What did the sleep study show? Normal. And then somewhere hidden in there, what was the clue? Moderate snoring. Right? Okay? And also, the kid didn't have any REM sleep. It took him like 320 minutes to get a little bit of REM sleep. It's very dangerous. Because the ENT doctor, what did they tell you? 2 ENT doctors said, don't take out the tonsillectomy, it's not indicated. There's no problem. Very dangerous. So, for some of these cases, we have a service that we provide at the Breathe Institute where I give out an alternate diagnosis. And my diagnosis will diagnose upper airway resistance based on 5% of sleep time snoring. I'm a reviewer for multiple I'm a reviewer and editor for multiple sleep journals, and there's this new article that just got published looking into upper airway resistance and saying that 5%, if you're snoring for 5% of sleep time, that is a diagnostic factor for upper airway resistance. Right? So when I interpret these studies, this patient snored for 12% of sleep time. That's not normal. Okay? This patient had primarily obstructions while in the supine position. So instead of saying normal, I give a diagnosis of obstructive sleep disorder breathing. Because obstructive sleep disorder breathing includes mouth breathing, snoring, upper resistance, and sleep apnea. And we're trying to move the dialogue away from just sleep apnea to encompass the whole spectrum so patients can get treated. Does that make sense? Is that helpful kind of a look at things? Yeah? And then I hope that you guys will take my reports and then go to your person and say, hey, how can we have you guys diagnosing not only apnea, but also obstructive sleep disorder breathing, which causes a huge issue in the patient's population.
Awesome. Thank you. So,
before you go further, what was her tonsil grade?
3.
3? Okay. Did that reduce after myofunctional therapy and improved nasal breathing?
Her nasal breathing has improved, actually. There you go. Her nasal breathing has improved from 100% mouth breathing during the day and night to 50%. And she's feeling less swollen, her throat's less dry. You know, and again, we're, you know, about 6 sessions in at this point where we referred her. So we're seeing improvement. We're seeing that she's feeling better. She's starting to sleep better. You know, she can elevate the tip of the tongue up to the spot, you know, at least half of the day. We're obviously working with her a lot on awareness as she's going throughout her day. She's wearing an N95 at, you know, in the hospital that she's working at. So we have some challenges around that as well. But she's, you know, slowly improving in that way. So, but she can't get that lingual palatal suction when she sleeps, right? And that's a big part of the snoring and not getting that lingual palatal seal and being able to maintain that through the night. So when we did her clinical tongue space assessment, you know, 1 out of our 3 red flags, her breathing's about a grade 3, but no scalloping or that tongue overflow that we looked at. So this was the treatment plan that was proposed to the patient. So she was recommended a deviated septum surgery, tonsillectomy, and expansion, and we can't move forward with the functional frenuloplasty until all 3 have been completed. So right now our patient's feeling frustrated and discouraged, financially overwhelmed, moving forward, and so we're in a place where we are a little bit stuck. So she doesn't want to remove her tonsils. She's not super interested in the septum surgery because she feels comfortable breathing through her nose. And so right now we're on a pause as we're trying to figure out what's our next path for this patient. So that's where we are at.
So,
Dr. Zaghi, would you ever, take kind of a patient out of the burning building, so to speak, would you ever recommend a CPAP for this lady and just to get her belly better and get her motivated?
Totally. So, in this specific case for positional sleep apnea, the CPAP would be hit or miss. You could consider it. She's not in a terribly burning building. This is a smoke more than a fire situation from my perspective. I just want to take a poll. How many people have had this experience in the past 1 to 2 years in their patient, in their clinics? Is this familiar to anyone? Right? Super familiar, right? Which is why we're discussing it. Here I just lectured on you guys and all the theory, but now as a patient in front of you, it's like real world. So let's first say, what would be the most ideal circumstance? To have the palate expanded, have the airway open, establish nasal breathing, tongue up before we do this. We all agree, right? Now, the thing we have to consider is, are we going to put the tongue picture back up? All right, put the tongue picture of the tongue. Okay, so based on our assessments, okay, go forward. Yeah. If we release it, I showed you anagrosis case, okay? It's going to scar back down. We know that. She's not going to get an optimal result if you release it. Yet, she wants to have this done, right?
Mm-hmm. Yeah.
Yeah. So she has it in her head that this is the next step. And this happens all the time. In these circumstances, what I would do in this case is I would offer the patient a small release as a step 1. Okay? Very small, don't bring the genioglossus muscle, just enough. Have a thorough discussion and get her quickly into expansion. And then when she comes back, later we can address the tongue, the stage 2. She's not going to have improved measurements after this. She's not going to substantially improve from the tongue tie release, but if that is the barrier and won't let her move forward, then we have to kind of weigh things and maybe offer her the release so that she can continue on her journey. So that's how I would have managed it. All of you guys would manage it differently, and I'd love to hear from you guys different opinions on this matter. She's improving with therapy.
Yeah, she's improving.
Yeah. She's improving with therapy. She doesn't have overflow, so she's not going to get worse. What's that?
Does she have any easy device like the X1?
No.
Yeah, so oral appliance therapy would be a good option. Okay.
Would you expect to see differences in your sleep study just with
Oral appliance they could work. Yeah.
Well, but just with Maya alone, just
maybe, maybe not.
What are you doing? One thing that I'm missing in the whole 3 days here is nasal patency.
Totally.
And we're all talking about the tongue. And we're talking about this person was 100% mouth breather, and yeah, we got a 50% improvement, but we never did. There's never been a discussion.
Totally.
How do we get this person to breathe into the nose when the nasal passage is constricted?
Absolutely.
And
So
I think there's our missing link.
I couldn't agree with you more. And so the FARIS 6 that we have for pediatric sleep disorder breathing, as well as all of our evaluations, the first step is definitely establish nasal breathing. We glossed over that even in my lecture here today because we're really focused on the tongue surgery. When we take a breathe course and we lecture on these things, you guys all agree, right? We talk about nasal breathing, how important that is, screening with the 3-minute lip taping test, lip taping for 10 minutes, 30 minutes, taking it forward, saline rinses, allergy management, turbinate reduction go there, a whole bunch of things that we can do to help establish that nasal breathing, and you're absolutely right about that.
Yeah, and she is lip taping at night, and she's noticing, again, that she feels like she does get enough air when she's breathing through her nose.
I think the learning point from all this is that the community has to kind of understand that it's not only about tongue tie and tongue tone, it's also about the tongue space, to really kind of put that on the map. With a narrow 30-mole inner width to the narrow nasal cavity, this patient would really benefit from some expansion. It could cure her, get her out of the smoke, get her out of the fire. That's what she needs. She may not ever need to have tongue tie release, okay? If you had to choose one thing, I'll probably see palate expansion. If she has it in her head and she won't proceed, I won't fault you for going ahead. Yes?
Will the expansion help with the septum?
It may help the nasal breathing enough that you don't have to do the septum. So I wouldn't push the tonsils and the septum as much, but I might push a little harder on the expansion.
Yeah, and she's open to the expansion if she feels like she can't get there with the tongue tie release. It's all three that are really tripping her up, between the deviated septum, between the tonsils, between the expansion, and just adding up the money, adding up the traveling nurse, adding up the, she's like, I'm in a different state every 3 months. Like, how am I supposed to do expansion right now at this point in my life? Because I can't be in the same place with the same doctor.
Soroush, I love what you said. So many of these cases, it's not about, it is about the procedures and the appliances, but really those are secondary. You have to look at the whole picture, including the patient's emotional and psychological place. Where are they with this? And we do this a lot, just doing something for the patient just to get through psychologically over the hump. The small release, and then going to an expander, she might think it's all because of the release, whatever, it doesn't matter. That's gonna motivate her to go to the expander. Then she's gonna start seeing, and then maybe the septum will be less severe when she starts expanding. Who knows?
Thank you. Thank you, Megan. Round of applause for sharing this case. I want to bring up my business partner and co-founder of the Breathe Institute. Big round of applause for Laylee. Laylee was pre-med around the same time as me, but she clearly has demonstrated, right, that she has been able to make a huge impact as a community member and a business person to help us all thrive in our practices. And I'm so grateful to have you as a partner, and she's such a wonderful resource. Who here's got to work with or meet Lily in one form or the other? Amazing.
Thank you, Dr. Zaghi. Did you all enjoy today's session? 3 hours did go by really quickly, didn't it? We're just going to take a quick second to answer a question I got asked a lot this weekend, which is what's next for the Breathe Institute? And before I answer that, I just want to give, I know Dr. Zaghi started by giving Dr. Pediatric and the amazing American Laser Study Club team and Light Scalpel team a huge thank you, but they've been such a supporter of the education and research we're doing. And we couldn't thank you enough, Peter, for just all of these support you give our education, our research, our teaching, and with that, said, I just want to share with you guys a lot at Dr. Baxter. It was amazing listening to Dr. Baxter lecture and share where the proceeds from his courses go. He gives back to charity and in such a meaningful way. And as you support and invest in your education, it should feel good to know that you're learning with thought leaders and pioneers that want to give back. We're so privileged to have Dr. Zaghi not just be a masterful clinician, but he is investing countless hours in research in our practice, and all of that is self-funded through our courses and all of our training opportunities. So we want to thank all of you because it's a very tedious and expensive effort to make it all open access for you all so that you can access it at any time, read it and learn it and be up to date. So I just want to take 2 seconds. I know we're a little bit over, and I'm going to have Chad airdrop our educational opportunities at the Breathe Institute, because I know, Peter, even your team, they're like, we don't even know what all the new offerings you all have. So we just want to share with you guys the different course opportunities, as well as some really exciting new, here we go, Dad. Exciting new things Dr. Zaghi and Chad are working on. So I'll just quickly start with our Breathe course offerings. Has anybody seen how quick Dr. Zaghi navigates his computer and presentation? Masterful. And a huge thank you to all of our ambassadors and affiliates for being here and supporting ongoing education. As Dr. Zaghi said, we love organizations and conferences like this because we get to come and give our updates, give our research updates, and share just highlights, right? But we spend so much time, for those of you who've taken our courses, look at how much more we are offering now just based off of all of the calls and requests that we get. So the Breathe course with Dr. Zaghi online has now moved into a hybrid model. So there's an on-demand that you have access to all year long, learn at your own pace, and then 3 days live stream. And if anybody's, who all's done the online course with Dr. Zaghi? He keeps it dynamic. I don't know how he does that for 8 hours straight, but it is a wonderful learning opportunity, and you get to ask questions live. So that's the Breathe course online. The Breathe Baby course is a 2-day course with Dr. Pinto, and that's phenomenal for any of you who want to delve into infant releases. Myo-Mentor with Sarah Hornsby is our foundational myofunctional therapy course. It's a 12-week program where you can learn all things orofacial myofunctional therapy. And then Sonda, please stand up again. Our amazing director of the Breathe Institute's orofacial myofunctional therapy director. This is essentially our residency for myofunctional therapy. It's a 9-month-long program. And has anybody in the room taken Lauren? Lauren, stand up for a second. Lyle, stand up. I want to give these ladies a huge round of applause. They committed 9 months of learning everything from oral sensory motor to orofacial myofunctional therapy. And then in person, we're so excited to be coming back in person. It's been 2 years that we've been doing things online. So we're working. Actually, there we go. The new offerings, the Breathe Surgical Assist course. So this is for your assistants, your orofacial myofunctional therapist, anybody who's supporting you all in the surgeries. Is going to be hands-on, and we're going to be teaching the intraoral, extraoral massages, and much, much more wound healing. We are so excited to partner with the American Laser Study Club to have a 2-day in-person surgical laser course. So if you've taken our Breathe course and just want to delve in and work on lasers, more wet lab, with Dr. Pinto and Dr. Zaghi, we do have the Breathe Laser Surgical course, and we are really excited to take the Breathe course, Breathe Baby, and Myo-Mentor for the first time ever as an in-person course opportunity. So the Breathe course in person will be June 8th through the 11th. Breathe Baby is October 13th through the 15th. We are actually adding a 3rd day just to do more hands-on with the laser and have Dr. Vitrick and his team lead that. And then Sarah, for the first time ever, is offering, instead of a 12-week online, a 4-day intensive advanced program in our Malibu Canyon, Calabasas office. And this is actually something we're really excited about. That's August 25th through the 28th. And I talked about the surgery assist. We are working with Robin Merkel-Walsh, for those of you who know how much Robin is dedicated to the field, to offer a scope of practice and ethics course. We are doing an on-demand suture training with Dr. Koppelson and content from Dr. Zaghi. And if you're interested in a lot of these learning opportunities, which many of you, a lot of our ambassadors end up taking 2 or more courses, we have an all-access learning membership that allows you to take everything with your teams. so that your teams can get caught up, and the different tiers actually offer practice management. So for anybody who was there for my presentation and heard about the team approach that's needed for implementation, there'll be a practice consulting component to that too. And also, without further ado, let me pull up the other slide. Okay, Dr. Zaghi, I might need, here we go. Boom. Can you all see that one? I might need your technical. So Chad, please stand up too. Where are you, Chad? He's always behind the scenes. I just want to give Chad a huge thank you. He's been working for over a year with one of the most brilliant programmers we've met in creating a software system that really is going to automate your workflow. It's task-driven. It's the first EHR, EMR that's task-driven, and it actually really helps take the place of the scribe. So when a lot of affiliates or folks that come to shadow Dr. Zaghi and they see him in his consultations, they're like, I wish we had someone like that helping get the notes ready, get them out. We created an automated software to do that for you and much, much more. I can send out information to anyone who's interested. Dr. Zaghi and Chad and a great chemist have been working on a breathe nasal rinse and wash that has surfactant to help fight off any viral load and a probiotic. Okay, so we're really excited about that, and we're in the final stages. We do have the functional frenuloplasty set that we promote through GenMed, and then we are almost done with, we're finalizing the coloring of it. One of our medical assistants, who's now a third-year medical student at Georgetown, I believe, is working with Chad to create this Goodbye Tongue-Tie animated children's book so that you can use it. Dr. Nora's been really instrumental in helping us get the behavioral component down with the kiddos. So this book is intended to give the kids, as you have the consultation, so they understand what's all involved and can really be excited about the procedure. So we hope you all appreciate this. I know we don't stop. Every single time we come to conferences like this and learn from all of you, we want to provide more and more resources. So thank you to all the speakers, ALSC, and Dr. Zaghi.